Got it. Thank you for your patience. If we could stand for the pledge, and Senator Rosenwald, would you like to lead us in the pledge?
Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
I would like to open the hearing on Senate Bill 86 and welcome the prime sponsor, Senator Rosenwald. Welcome.
Thank you. Thank you, Madam Chair. For the record, I'm Cindy Rosenwald, and I have the honor to represent Senate District 13 in Nashua. And I'm pleased to introduce to you today Senate Bill 86, which will strengthen the healthcare workforce we need for the health and well-being of our people and our economic vitality. This bill includes several program initiatives as well as Medicaid rate increases. I won't skip over the fact that the bill contains nearly $160 million of appropriations, but I know that's not the primary focus of this committee. When I was first elected in 2004 and appointed to the House Health Committee, probably the first thing I heard was, our Medicaid rates are too low. They're the worst in the country. And Madam Chair, this statement is as true today as it was 18 years ago. But because New Hampshire's a small state with great nonprofits, a place where it's possible for a provider to pick up the phone or an agency and say, hey, I've got this person who really needs help. Can you pitch in? The system has kind of held together all these years. But when COVID happened and there was an incredible pull on all of our providers all at once, the cracks that were always there became so broad and so deep that I think we can say our entire system is now truly in crisis. Our providers can't hire the staff they need to operate the capacity they could have. It's difficult in New Hampshire to get a hospital bed if you need it. And it's difficult for hospitals to transfer patients out to a nursing home because they can't staff all of their capacity. Hospitals have lost 6% of their staff since the pandemic, and long-term care facilities have lost 9%. I'm sure you've all heard from your area agencies that their clients aren't getting the services they need and are approved for because they can't hire direct care providers. And in the Choices for Independence program, providers and case managers have told me that potential clients are frail elderly, are literally dying before they can be served or even evaluated. Both children and adults are experiencing higher need for mental health treatment, and in too many cases, not getting it in time to prevent our ER boarding crisis. So we simply can't go on this way and expect our Medicaid program to be sustainable. Several years ago, we provided for 6% across the board rate increases. This was very helpful, but not really enough, particularly given the strain we're now experiencing across the system. So the rate increases in this bill would be determined by the department according to levels of need, not a consistent across the board rate increase. So, okay, enough about Medicaid. This bill will also develop our healthcare workforce in several other areas. Sections 4 and 5 of the bill direct OPLC to begin the process of certifying community health workers. These are non-clinical staff that are at home in minority and underserved communities, freeing up the time of clinical staff so they can work more efficiently at the top of their scopes of practice. Certifying community health workers will allow for their services to be reimbursable. Section 6, which begins at the very bottom of page 5, directs DHHS to issue an RFP to increase the number of entry-level clinical staff in rural and underserved areas. Such programs may include school-based programs that introduce the health professions, advanced programs to mentor nurse practitioners to work in health centers, and a teaching health center-based medical residency program in family practice. Sections 7 through 9 contain the appropriations for all of the above. I'm happy to answer questions, but there are subject matter experts here who are much better prepared to talk about their specific areas. My hope is that the committee will understand the need for further work on the money parts in finance and move this bill positively to the Senate floor. Thank you.
Thank you, Senator. Any questions from the committee? Senator Prentice.
Good morning, Senator Rosenwald.
Good
Thank
morning.
you, Madam Chair. And I don't know if this is a question for you or one or a subject matter expert, but on the community health workers, I appreciate the placement of them, the contemplation and the placement of them in this bill, because I think that this work is so important. Especially we saw during the pandemic that the bonds, the bonds that the healthcare can make with different communities to bring them into the system of public health for treatment and for resources is so key, and that's a big part of what the community health workers do. So my question is, I believe I heard you say that they can bill for the services. Did community health workers
Yes,
can
they
bill?
could be able to. So I believe that would be a contract negotiation, but if they're not certified, they can't be reimbursable,
Okay, follow up.
as I understand it.
And I think that was going to be my second question. So here's the third one, which is now number 2. We do have, using some CDC money and working with former Commissioner Shibinette and the department, we're able to put community health workers, not full-time, but almost like 3/4 time in probably 10 of the public health networks. So do you see how this group would, if they wanted to do it, would transition into becoming certified? Because I think that would be a real benefit for the public health networks.
I think the community health workers who have already been here at work in New Hampshire likely are going to want to stay here.
Yeah, I do too. Okay.
And there is at least one community health worker here today to speak.
Yay. Okay, good. Thank you so much.
Thank you.
Thank you.
Any other questions from the committee? Senator
Yes.
Bradley.
So, section, I think it's 8, the appropriation. When we did the 3% and 3% Medicaid rate increase, what kind of general fund impact did that have
That had a $30 million general
per
fund
year? Or it was
total.
total?
I think it was 30 million total. It was originally scheduled to become effective on July 1st of each year of the biennium. We pushed it each one back 6 months, and I think we were able to get it to about $15 million a year.
All right, well, the department's here, so they can.
The department's here, and I would just remind people that we're talking about a Medicaid program is a $2.5 billion program each year. So, yeah, this is a big amount. It would translate with the federal funds into just over 300 million on a $2.5 billion program. But there are other people who can talk about how they got to that number
Okay.
for consideration.
Any other questions from the committee? Seeing none?
Thank you.
Senator. Henry Lippman? Welcome. Morning.
For the record, Henry Lippman, the state's Medicaid director. If I could maybe pick up where the conversation in the previous section was, I've been working with the actuary to try to get a sense of what this is. And what I'm about to share, I've had a chance to have a direct conversation. I just got this in last night in terms of numbers, but what we would forecast, assuming that the 145 was 72 and a half each year of the biennium, and assuming it was just for services as opposed to supplies or things that aren't services, basically things that providers do. So we modeled it with them for both standard Medicaid program and Granite Advantage. In terms of the standard program, if we included that, the 72.5 million all in the standard program, because general funds can't be used in Granite Advantage, that would yield about 11% increase over current rates based on 22 claims. We also looked at 19 data, which doesn't reflect the rate increases that Senator Rosenwald talked about. It would be 13%. So it gives you, I think, a general sense of it. Then looking at Granite Advantage, because we would have to appropriate that money through the funding sources that would exist under that program, it would add approximately for the 10% share, almost $4 million, $3.99 million would need to be raised through that source for Granite Advantage using the 22 data, and just under $3 million for using the 19 data, $2.98 million. I think that obviously the policymakers are going to have to decide what amount of funding they're comfortable, whether it's this full amount or another. I think it's fair to say that providers are experiencing significant cost increases for labor. We see pressures, particularly in the home and community-based services area, private duty nursing, the whole thing that, we're having difficulty getting all the assessed care hours that people have being fulfilled. In part, I think is related to the difficulty in recruiting staff. Part of it, I think, is also maybe some of the other things in the bill or in other bills in terms of, increasing the workforce, because that's needed as well. I think we see pressures. Last legislative session, there was a 25% increase for maternity care and hospitals, which I think was important. We've lost 10 providers in that space over the last decade or so. And then ambulance is another area that was addressed last session. We brought our rates up to 50% of Medicare last session, which I think was really important. But we were seeing challenges in getting facility-to-facility transfers accomplished because of the shortage of workforce in ambulance care, but also that, given the reimbursement rates compared for different types of services, that because there's a workforce shortage, that the agencies tend to focus on the ones that are going to make them financially viable. I guess suffice it to say is that the department would advocate for rate increases, but we understand that this has to be looked at in the context of the entire budget. So happy to answer any other questions.
Senator Prentice.
Thank you. Thank you, Senator. Good to see you, as always, Henry. And I think you already touched on what I was going to ask you, which has to do how this applies to ambulance services and their workforce shortage. So when you're talking about in number, it's, on the first page, the Commissioner of the Department of Health and Human Services shall increase the Medicaid provider rates, including all state plans, and it goes on. Do you contemplate that will include
Yes.
ambulance providers?
It would. I think the important part of this bill is, I understand the previous increases, the 3.1%, the two that were given consecutive were across the board because it's been a long time before there was a, you know, a large increase across the, but I think what I think is appropriate and important about this bill allows us to look at the areas of most sensitivity where access is a larger issue in one area or another. But ambulance is honestly an area of concern of mine in terms of what I hear in the field from nursing homes, from hospitals. It's important.
Thank you very much, Henry. Thank you.
Any other questions from the committee? Seeing none, thank you.
Thank you.
Greg White?
Sorry. Good morning, Madam Chair, members of the committee. Thank you for your time this morning. My name is Greg White. I'm the CEO of Lamprey Health Care. We're one of your state's federally qualified health centers with sites in Nashua, Newmarket, and Raymond. We also have a number of integrated sites and a mobile health unit where we visit our patients in the community. Our services include family medicine, OB, pediatrics, behavioral health, and substance use treatment. We deliver those services through over 60,000 patient visits annually. Key to the provision of these services is our workforce, our dedicated doctors, nurses, medical assistants, counselors, and other supporting staff that provide care to those most in need. As you've heard earlier, we're facing some pretty severe challenges with our workforce in our ability to recruit and to retain. Our ability to pay these professionals in light of a very, very tight labor market is very constrained by the reimbursement we receive for services. As a federally qualified health center, we exist to eliminate barriers to care, to address the disparities that people face in the reception of their care. Due to this, typically our largest payer is Medicaid. Medicaid represents 40% of our patient revenue. And as you might imagine, that's important to how we keep the organization running. As a service organization, the majority of our costs are staff and staff-related costs like health insurance, which have all seen huge increases over recent years. At present, Medicaid reimburses us at about 80% of what it costs us to deliver care. That equates to about $1 million shortfall annually. And we don't have the unrestricted resources to sustain that sort of shortfall. Despite an annual adjustment based on the Medicare Economic Index, our Medicaid reimbursement rates have not kept pace with the very real growth of salaries and fringe benefits in many years, which are almost double this index that is used to adjust our rates. So as you might imagine, that deficit compounds itself year over year. And then add to that the impact of COVID, which we're still working through. So I appreciate your time this morning. I appreciate your consideration of this bill, and we would be happy to answer any questions.
Any questions from the committee? Seeing none, thank you.
Thank you for your time.
Welcome.
Thank you, Madam Chair. Thank you, members of the committee. Thanks for the opportunity to weigh in on Senate Bill 86. My name is Ken Gordon. I serve as the CEO of Coos County Family Health Services. We too are a federally qualified health center serving the Berlin, Gorham, and Colebrook region of the North Country. We provide care for more than 12,000 residents and provide primary care services, dental services, and behavioral health services. I'm here today to emphasize the provisions of the bill related to rural health and primary care. A call for funding to support the development of a rural residency training program. This type of physician training is relatively new and is part of a new federal initiative to increase the number of primary care physicians providing care in rural and underserved areas. Research has shown that the majority of medical residents settle and begin their careers in communities that are located within 50 miles of where their residency program is located. The notion of growing our own doctors rather than on relying to recruit from outside the state is an attractive proposition and one that's worked for many other states around the country. Last year in 2021, we applied for federal funding and received federal funding from HRSA to establish a family medicine residency program. We did that in concert with our hospital partners in the region, that is North Country Health Care, three hospital consortium of rural hospitals. When up and running, this program will host 4 residents each year, a total of 12 residents when the program is fully operating. It's designed to create board-certified family physicians who are particularly focused on serving rural and underserved communities and the people who live in them. We're now in the process of sorting out the financial support that will be necessary for the program to be sustainable. The federal government provides essentially 65% of the cost, but other funding is needed in order to support the program. Many states provide funding to support rural residency programs around the country and have successfully used this strategy to make sure that the healthcare workforce is adequate in their states. This appropriation will leverage matching federal funds and philanthropic support. It represents a critical component to the successful launch of this program, and in our view is a strategic investment that will yield multiple returns in the forms of more family physicians, better health outcomes, and healthier New Hampshire communities. Thank you. Happy to answer any questions.
Any questions from the committee? Seeing none? Thank you, Ken. Sorry about Kel versus Ken.
Thank you.
I know you do.
Alex?
Katrubis? Okay. All right, I'll move down. Joe Bohanicki? Oh, sorry.
I was watching you on YouTube.
Alex.
There must be a delay. Sorry. All right. Good morning.
Welcome.
Make sure this is off. TV. All right. Good morning, Madam Chair and members of the committee. Alex Katrubis. I'm here to represent several human service and healthcare organizations, all of whom provide critical services to many of our state's most vulnerable residents, and they are all in strong support of Senate Bill 86. We all thank Senator Rosenwald for bringing this very important topic of healthcare workforce forward and providing us with this legislative vehicle to advocate as part of the Healthcare Workforce Coalition. So I'm first going to talk about the New Hampshire Healthcare Association. So New Hampshire Healthcare Association represents New Hampshire's private nursing homes, many assisted living facilities, and Cedar Crest Center in Keene. Brendan Williams, who is the group's president and CEO, has already emailed you his testimony. I'm again providing you with a copy of it here this morning. I'll get right to the point because I know you have a lot of speakers. New Hampshire has the second worst nursing home staffing shortage in the entire country, and that is according to the latest AARP dashboard. Nursing home staffing shortages in New Hampshire are twice as bad as Vermont and 7 times worse than Massachusetts. At the public hearing on Senate Bill 36, the Healthy Aging legislation, I presented you with several letters from nursing homes around the state. I won't go through them again, I promise, but they are updated in the packet that you were just handed to. Those letters were sent to Department of Health and Human Services and to Gopher, pleading for assistance from the ARPA program, because nursing homes in the state right now are currently hanging on by a thread. I also want to talk about wait lists for nursing homes. Right now, many facilities have wait lists of up to 100 people. But at the same time, beds, units, and wings are offline. When nursing homes turn people away, that backs up the state's hospitals and other health systems. Other states are acting on this issue. Last year, state nursing home rate increases ranged from 17.5% in Pennsylvania, 20% in Nebraska, and 23% in Wisconsin. So the legislature must raise nursing home rates this legislative session with state dollars. And we look forward to working with the Senate to include our proposal on rates in this legislation. Next, I want to talk about residential care homes. This type of service and living aids with personal care, social activities, and health services from trained and appropriate staff, all under one roof. Assisted living provides safety and security that many older adults require. In New Hampshire, there are approximately 6,000 licensed assisted living and supported residential care beds. Only about 500 of those are Medicaid beds. That's according to the latest dashboard presented to the Joint Fiscal Committee. So 6,000 total, 500 are Medicaid. So therefore, Medicaid is not a big part of assisted living in the state. However, it is an important, there is an important role for assisted living under the CFI waiver. And currently, low-income seniors can take advantage of assisted living through CFI, and without this option, they obviously would not be able to afford this type of a program. Right now, New Hampshire Medicaid pays about $57 a day for most residential care homes, $57 a day. And if the legislature were to adopt the department's agency budget request to the governor under prioritized needs, this rate would go up about $1.70 a day. And I don't think anyone thinks that that's going to help at all. So that's why we are currently exploring reasonable solutions that we think can have an impact. So again, please look for more information from the assisted living community that they will present to Senate Finance and all of you. Meals on Wheels, as I mentioned again at the Healthy Aging Legislation public hearing, for the fiscal year ending June 2022, the 10 agencies around the state distributed 1.8 million meals. About 246,000 of those are Medicaid funded. So again, like assisted living, Medicaid is not a huge component of senior nutrition, but it does serve as an important part of the system. For example, Stratford County, Meals on Wheels, CFI is 16% of their meal population and 22% of their overall revenue. And when a person gets a visit from a Meals on Wheels provider at their home, often that's the only person that they will see that day. So this wellness check, as I know a lot of you know, is just as important as the food that's being delivered. The Meals on Wheels providers do support the department's prioritized needs request to the governor, and we believe that that proposal recognizes the large increases in demand that they have seen during the pandemic and has continued as we've moved forward. And again, we hope that Senate Bill 86 and/or the state budget can reflect those needs for senior nutrition. The last group I want to talk about is DD, developmental disabilities and acquired brain disorders. I'm speaking today for the 10 area agencies that provide and coordinate services for over 14,000 people in the state. Developmental services is 14% of the department's overall budget. 95% of that is Medicaid. And that number is high, obviously, but you have to keep in mind that the area agencies serve individuals from birth through their entire lifespan. The very first services that many children receive in the area agency system is family-centered early supports and services. Some children who receive these intense early interventions never become a Medicaid recipient. ESS is one of the most effective and popular programs in developmental services, and we need to make certain that this legislation and the budget include a rate increase for ESS. Some of you may remember we did that in 2017. But by far the largest component of developmental services are the three Medicaid waivers: DD, which is for adults, acquired brain disorders, which is also for adults, and in-home support, which is for children ages 3 to 21. Beyond providing a federal match, these waivers enable us to offer a wide array of home and community-based services that assist people with developmental disabilities to live in their own community with their family, as most of them do. Some live in small certified residences, others live independently, and they only require minimal assistance. All of the services are tailored and individualized to meet individual needs. And as you have seen with other healthcare systems, the area agencies and their direct service providers have faced unbelievable and never before seen workforce challenges in their mission. I'm including a letter, I will give it to you right now, if I may. I'm including a letter from the executive director of the Lakes Region Area Agency, Region 3, that speaks to their challenges with workforce. The area agencies are competing with restaurants, retail, and other employers that can offer high wages. To understand and respond to this, the area agencies have been tracking staff vacancies and other important human resource data, and I've included in what you're being handed right now the latest HR report from the area agencies. I've also distributed a copy of the history of rate increases to DD from 1996 to the present. You can see that the vast majority of those years, there were no increases. Now, to be fair, there obviously was wait list appropriations during those years, and that's very important. But the problem is if you came off the wait list 10 years ago and there's not a rate increase, your budget is the same unless your needs have changed. According to a recent report of the Health and Human Services Oversight Committee, the DD and ABD wait lists are fully funded. However, the top sheet that you were just handed out, the pie chart, shows that over 30% of the people who are projected to be served in fiscal year 2022 are not receiving any services. So we funded the wait list, but only 70% of the people, and even of the 70%, not all of those folks are getting the complete array that they need. Not what they want, but what they need. And the number one reason why those services are not being delivered is staff and provider recruitment challenges. And that was a survey that was done by the department. You can see the area agencies and the providers responded, and that was the number one reason. Not a surprise to anyone. So we have funds available, we have demand for the service, but we can't execute. We can't execute the budget that you all passed. So how do we solve this? The area agencies, again, are working on a specific rate request proposal that we believe can help alleviate some of the staffing issues. And again, look forward to working with Senator Rosenwald and all of you in Senate Finance on this issue. I did want to mention, in addition to workforce, as many of you know, the area agencies are under a corrective action plan from CMS. This is a fundamental change to developmental services in the state. As most of you know, many of the area agencies were founded in the late 1970s and early 80s. We've built a system over the decades that in some ways needs to be reconfigured from a pretty fundamental level. The two main issues in that corrective action plan are Medicaid direct billing and conflict-free case management. The planning for these changes was obviously disrupted by the pandemic, and it's been difficult for the agencies to focus on the system change during the pandemic, but also during this workforce crisis that we're all facing. The current implementation date for the CMS plan is July 1st, and there's still a lot of work to be done. Currently, New Hampshire only allows the area agencies to bill for Medicaid services, and CMS again has told us that we must allow as a state all providers to bill directly to the state. So we must comply with this requirement. However, the specifics of how we comply are very much in the state's control. We must change, but we have to do it correctly. We have to do it right. So as a result, the next state budget must include the correct level of funding for the administrative rates that will be required to implement direct bill as required by CMS. This new system rate is called the DADS, and again, it's critical to ensure that the current area agency infrastructure remains intact and operational so that the services are not disrupted post July 1st. So again, we would ask the legislature to stay engaged on that important issue. That's really all I have, Madam Chair. I just want to commend all the groups that have come together to work on this issue. I think it makes a lot of sense for us to be here with one piece of legislation, a comprehensive plan, rather than 12 or 15 different bills. So I thank you all for your attention. Appreciate it.
Thank you, Alex. Any questions? Senator Abar.
Thank you. Just one quick question. Does this bill help out with the dad situation with the CMS and all that, July deadline?
Thank you for the question. It can. It is our hope that it will. But we need to write it in a way that it does. Right now, it's just a blanket 12 to 13% increase in Medicaid, the current Medicaid spend. But we don't have the details filled in terms of how that would be allocated to all the systems that are coming before you today.
One
Follow
follow-up.
up.
Can our federal delegation help kind of scoot that July up a little bit so it gives them a little bit more time?
That's a great question. Potentially, yes. I mean, I think we're working diligently as a system to try and meet the current deadline. But obviously, if we're not ready, we may have to ask for more time. And certainly the delegation may be able to assist us with that. It's a sensitive topic, obviously, because we've been trying to work this out for a long time, and it's already been delayed a couple of times, again, because of COVID and other issues that have come up. So I think the delays have absolutely been justified. But I think there's a resistance at the department to ask for a delay at this stage. I don't think we're quite ready yet. Let's see what happens in the next couple of months, but we may get there. You're welcome.
Any other questions from the committee? Seeing none. Thank you, Alex.
You're welcome. Thank you.
Joe, sorry about that.
Good morning, everyone. Thank you for allowing me to speak today. My name is Joe Bohaneke. I'm the administrator at Mount Carmel Rehab and Nursing Center in Manchester. We're part of the New Hampshire Catholic Charities. For those of you that don't know about Catholic Charities, we have 7 nursing homes throughout the state, with some with independent and some with assisted living. We are happy you're working on the additional appropriations for the workforce development. Currently at Mount Carmel, we have 30 open nursing positions. A lot of our shifts are filled with our nursing staff, but more of them seem to be filled with local and traveling agency. In the past 9 months, we have spent $1.2 million on agency staffing. Why? Because there is no additional staff out there for us to hire. Due to this lack of staff, we've also had to lower our occupancy to 76% of capacity by denying admissions. Hospitals are getting angry with us due to the limitations we have put on these admissions because they have no place to send their more critically acute patients. We need help. Again, I thank you for your support of this bill.
Thank you, Joe. Any questions from the committee? Seeing none. Thank you. Thank you for your patience. Paula Minahan? I know.
Good morning, Madam Chair, members of the committee. For the record, Paula Minahan, Senior Vice President, State Government Relations for the New Hampshire Hospital Association, representing all 26 acute care hospitals as well as our specialty hospitals. We are in strong support of Senate Bill 86, and we do thank Senator Rosenwald for bringing this important legislation forward. We do want to focus today on a couple sections of Senate Bill 86, and I will not, I will reference the report that I attached, but obviously will not read it for the interest of time, but I do encourage you to look at that. One is the provision for certification of community health workers. These are very important services that our hospitals do employ them, but we do not get they do not get reimbursed for these services. So by passing Senate Bill 86, it allows the Office of Professional Licensing and Certification to be able to promulgate rules to establish certification criteria, as Senator Rosenwald outlined, and as she said, there are folks here today that are experts in this area, but I just wanted to point that out, that is very important to our hospitals. It has come up over and over again in their population health efforts, and this would be a very important component.
We also support Medicaid rate increases. Specifically, hospitals are requesting targeted rate increases for both behavioral health providers as well as long-term services and support services to include both home and community-based providers by home care agencies as well as long-term care. And I have attached a report that we published recently. It's 2022, barriers to discharge. And you will see that patients across the state remain in hospitals beds when they no longer need acute inpatient care. This is becoming a crisis. They cannot leave because there is nowhere for them to go safely. These barriers range from lack of available supports in the communities to insufficient long-term care beds to legal barriers. In other words, it's not medically necessary that these patients remain in the acute care facility, but in part due to lack of available community services and resources, these individuals cannot safely be discharged. Again, I encourage you to review the report, and I'm happy to answer any questions that you have. And by the way, hospitals don't receive reimbursement for these non-medically necessary days. And the other compounding problem, and I think some of you have experienced this personally because I have talked with you about this, they can't get patients in because they can't get patients out. So it's becoming a real crisis. Our occupancy rate for any given day is over 96, 97%, which is unheard of. And this is just unheard of. So again, some hospitals are over 100%. So it's just becoming a real problem. We are requesting that there be targeted rate increases for both long-term care services and supports as well as behavioral health. And regarding behavioral health, we do sincerely hope that these rate increases can help them with additional resources needed to hire personnel and to increase the number of patients they're able to serve. This will greatly, again, assist our hospitals in ensuring that these individuals get the community-based behavioral health services that are able to access them, and they could hopefully avoid a crisis and then avoid getting into the unfortunate situation that you are all well aware of behavioral health patients boarding in hospital emergency rooms. As of yesterday, we had 73 individuals waiting in hospital emergency rooms, 56 adults and 17 children. We need to find long-term sustainable solutions to this crisis, and we ask that you consider targeted Medicaid increases to these much-needed services. Thank you, and I'm happy to answer any questions. Senator Bradley.
Thank you very much, Madam Chair. I'm assuming that you were referring to Section 9 and the $500,000 appropriation for the licensure.
Regarding community health workers, yes. And I think Senator Rosenwald, I think Section 6 has to do with the, there's a whole section on community health workers, but yes, as far as the appropriation, yes, I think you're right. I am not an expert on this bill. There are others that are, but
Okay. All right, thank you.
but I think it's also the 1.5 million on page 7.
Yep.
Yep. Yep. Senator Avard.
Thank you, Paul, for your
Sure.
your testimony. Just, you did say that there's a 97%, occupancy rate, and there's some that are over 100%. So I assume that over 100% are the people waiting in the emergency room.
Mm-hmm.
That is.
Yes, unfortunately.
Is there a time period that they're waiting in that emergency room? Yes, just a follow-up. Thank you.
I can get, it varies. Unfortunately, I think it can be days sometimes, hours to days. It depends. What also happens is we have heard from our critical access hospitals, they can't move. A critical access hospital, as you know, typically stabilizes and gets them to a higher acuity. If they need a higher acuity, they will get them transferred to a larger community hospital. They can't because, again, those hospitals don't have any room. Dartmouth Hitchcock is a perfect example, unfortunately. So they get backed up in critical access hospitals as well, which is, again, it's not good for anyone. And we are, again, that's why we believe we're in this crisis situation, and that's why we are specifically requesting that these increases be focused on those areas that we believe are causing these barriers. And as Alex Trubis has said, nursing homes are unable to staff so they cannot open up the beds that they have beds. They just have closed units in nursing homes, which is again a real problem for us. You're welcome.
Any other questions from the committee?
Thank
Seeing
you.
none, thank you, Paula. Stephanie Pagliuca, welcome.
Good morning, Madam Chair and members of the committee. I'm Stephanie Pagliuca, and I'm the Senior Director of Workforce Development and Recruitment with Bi-State Primary Care Association. Bi-State is an organization focused on promoting access to preventive and primary health care for all, with emphasis on the needs of medically underserved individuals and populations. The members of Bi-State are some of the community health centers you heard speak this morning, but community health centers, federally qualified health centers, who provide direct patient services in primary care, oral health, mental health, and substance use disorder treatment services to meet the needs of their communities. There are also members of Bi-State, such as the New Hampshire Area Health Education Centers and other networks and consortia that support the mission of Bi-State to promote access. I've been the director of Bi-State's Recruitment Center since its inception in 1994. The Recruitment Center focuses on attracting and helping community-based practices, the health centers, but including hospitals and other types of private practices with recruitment of physicians, nurse practitioners, physician assistants, dentists, and more recently, mental health and substance use disorder treatment providers. So these are the community organizations that we just talked about who are employing the health professionals that are providing that primary care. We do this by reaching outside of the state to promote New Hampshire practice opportunities and getting individuals who are in training and in practice outside of the state interested. Our team will then work with those individuals to kind of direct them to communities where there are vacancies for their type of specialty, as well as where their professional and community and personal needs can be met, so that they can be integrated into the community. We will work with any type of organization that recruits these folks. We've helped over 100 organizations in New Hampshire to recruit more than 630 practitioners and many others, many other individuals we talk to each year who may be interested but not yet available or might find an opening in another state that they prefer otherwise. But even before the pandemic, we knew that we weren't training enough family medicine individuals, and we're not training enough practitioners in our state to meet the needs. So prior to the pandemic, and it wasn't just a pandemic, but our history is that we train 8 family medicine residents. We graduate 8 family medicine residents from the Concord Family Medicine Residency Program each year. There are many more openings across the state for family medicine doctors each year than 8. And so we must reach outside of the state. There is also a new program in Portsmouth that has come up, and we'll add to that. And Mr. Ken Gordon spoke to the rural residency program that will also add to that with individuals who are trained in a rural community setting. So we knew that we were not training enough practitioners in the state to meet the needs. That national marketing and outreach that we do at the Recruitment Center is very important then, because that's where the pipeline is coming from, one of the sources of the pipeline to feed those vacancies and direct people to those communities. So we're very pleased that this bill is being considered and the provisions therein, because they're all very practical and important things to help us develop a pool of practitioners for the long term right here in our state. We'll never eliminate the need for having to go outside of the state, but we really don't have the folks from within the state to address these workforce needs, and they don't have the experience here. So they're, as Ken Gordon spoke to in his testimony, folks who train here are more likely to stay here. They have that experience. So we are very impressed with the community health worker certification, the investment in New Hampshire Area Health Education Centers to develop those pipeline programs, not only for later career, but also for early career and growing people into the health professions. The additional training for advanced registered nurse practitioners is very important, as the patients that they're caring for are very complex, and a new graduate from a training program may not have that experience to be able to address those complex needs. And the rural family medicine program residency that Ken Gordon spoke about is really the first opportunity for residents in New Hampshire to train in a rural area, and it's very exciting. So these are exactly the types of programs that will have a significant impact on the recruitment times, helping to reduce recruitment times over the long term, because we'll have a pool of applicants right here in the state. as well as really helping have those practitioners with experience in the types of communities where their services are needed. Because our current programs are in larger communities in southern New Hampshire. They don't ever get to really drive around and see and experience what those other opportunities are like. So when it comes time for job searching, they're certainly going to look for something that's more familiar to them. So we'll never eliminate that need to reach outside of the state, but we look forward to working with the organizations who will build these programs, because we have great systems in place to help recruit and retain these folks for the state. So thank you for consideration of this bill, and please let us know if you have any questions.
Any questions from the committee? Senator Prentice.
Thank you, Madam Chair, and thank you for coming and speaking this morning. When I worked at Concord Hospital, I had the opportunity to work with members of the residency program that you spoke about. So thank you for sharing that. You talk about your 29 years of experience. That's a long time, and the number of providers that have been recruited was 630. Do you have and I might have missed this, a sense of, from the residency program itself, coming in and training here, how many from a retention perspective, how many do stay? And if I missed that, I'm sorry.
No, I didn't speak to that actually. So in the historical data that I've received from the Concord Family Medicine Program is about 50% of the individuals who train stay. And they tend to stay in the central and southern New Hampshire area, which is great because there are openings for them here. So it's wonderful to be able to retain in the state. So they have about a 50% retention rate from what I know.
Okay.
Any other questions? Seeing none, thank you.
Thank you. Thank you.
Christine Field? Welcome.
I'm Christina Field-Sparks. I'm the director of the thank you. I'm also a resident of New Hampshire. I live in Lyme, New Hampshire, and I plan to retire here. Yeah.
Hey, nice to see you.
So, pardon me, I'm a little nervous today, but let me tell you a little bit about the AHEC, the Area Health Education Center. We've heard a lot about our workforce shortages, and I think every speaker before me has talked about them, and that's why we're here. So, in 1970, the Carnegie Commission looked at the future of the workforce in our nation, and it was clear back then. This is shortly after the passing of Medicaid and Medicare, that we are facing a sizable workforce shortage. So at that time, they appropriated resources for community health centers, the bricks and mortar location, and the area health education centers. And the AHECs are designed to recruit, train, and support the workforce for those community health centers. So over the years, since 1972, AHECs have been funded throughout the country. And in 1997, the New Hampshire AHEC was funded. It's housed at there by all AHECs are housed at either a school of medicine or a school of nursing, and most of the resources go out to the community through the partnerships that we have. So in New Hampshire, of course, we have one medical school, and that's where we sit, the grant, but most of the resources go to the Northern New Hampshire AHEC and the Southern New Hampshire AHEC to build and support the workforce, the healthcare workforce. So some of the programs that we run and we have run with these limited resources from the, it's a HRSA funded program under the Bureau of Healthcare Workforce, is we build programs for high school students currently, but we also have built programs in the past for younger students to attract them to the healthcare workforce. And the data shows that the strongest predictor of the future is that if we can grow our own. So students from rural communities tend to go back to those rural communities after their training. So with that in mind, we build our programs focused on New Hampshire students from these communities, and we try to expose them to careers in healthcare all throughout, right up through high school. We run a residential program at Dartmouth College where students they live in the dorms and they're exposed to health careers. So it's limited, but we do have the infrastructure in place to build these programs and to blanket the state with these programs. So Thank you.
Nice job.
Yeah.
Any questions from the committee? Seeing none, thank you.
Thank you.
Jim Monahan?
Thank you, Madam Chairman. I'm Jim Monahan with the DuPont Group. I'm here on behalf of a lot of folks this morning, but in particular, I'll focus on some detail on the community mental health centers. But just to provide some context for the bill and how it got to the committee today, Alex Achubis made reference to an informal healthcare workforce coalition that has been organized over the last couple of years to try to pull together the safety net healthcare providers so that when we approach state government, we do so in somewhat of a organized fashion so that folks aren't getting a hodgepodge of information coming out them. We try to pull people together. We think it's helpful to you. It's probably good for us too, so we can avoid Survivor Island, where we have to vote people off the island, and we can all work together. That worked very well previously when we worked with the legislature to enact 3.1% rate increases for Medicaid providers. And as Henry Lippman observed earlier, that type of approach is probably a little more challenging in this upcoming legislative session because many providers have been affected differently by the workforce and by the COVID issues. So what you have before you today in House Bill 86, I think is, at least my view on it, is it's really dealing with three key issues: access, pipeline investments, and retention of what I think is a great Medicaid system, but does need some investment in that infrastructure. With regard to access, I think everyone in this committee knows that the Medicaid program is one that the federal government invests with the state and sometimes the counties in. To make for a system that works well for everybody. But there is a requirement under this program, because it is an entitlement program, that those who operate it, and in New Hampshire that's the state government, it's not all Henry Lippman, it's all of us as well, have to provide access for those people that have entitlements to the programs. And when we look at many of the issues that are before us today around workforce, it really does affect access. In a minute, I'll talk about how that's affecting the community mental health centers. The bulk of this bill, as you see, of the many sections of it, deal with pipeline investments, and Steffi and others talked about that in addition to trying to retain what we have, we also need to build a workforce. When we get into Senate Finance and some of the appropriations decisions here, you'll see that many of the dollars associated with the pipeline sections of this bill could probably be viewed as one-time monies in an effort to create a surge in pipeline investment. There was some of that in the use of ARPA funds. The Healthcare Coalition that I referenced did more than a year ago put together a menu of investments, one-time investments that we thought that Gopher should take a look at as a way to stimulate the workforce. They got through some of those, but not all of them, and some of those that were not funded found their way into Senate Bill 86. So there was some long-term consideration by a group of providers to come to you with the pipeline investments that you see today. Finally, let me focus my attention on what is before you as sections 3 and 8 of this bill, and that are the sections that deal with the Medicaid rate increase. 3 talks about how it would be structured. 8 talks about the dollars and cents that would be associated with it. We're in the process now of, I was because much of this might have emerged in the budget process, I was going to make reference to this as spring training so that I could get Senator Bradley's attention on this, but I don't. That hasn't happened yet. So, what we're attempting to do is create an inventory of need. So we've invited all the major Medicaid providers to the table to work with each other to understand what the needs are of each provider group and ensuring that those needs, when they're presented, are justified. And then collectively, we all want to understand each other's needs so that we get behind a single proposal. That's what we have in section 3 and 8. That inventory isn't completed yet because folks are still diving deep into what do they need relative to the costs, and how is that translated appropriately to a adjustment in rates. Some have advanced that. I think everybody's goal is over the next few weeks to put that inventory together for you. But it was the early stages of estimating what those costs were, which led to the Section 8, which is the $145 million appropriation. Senator Rosenwald indicated that would allow us to draw down probably a little more than $145 million in federal funds, and as a percentage of the $2.5 billion Medicaid budget. While it looks like a challenging number, we think it's not inappropriate to begin the process by looking at it in those numbers. As the bill moves through the process, we hope to put more meat in the bones on that. But one thing I did want to add some emphasis on today is the work that the community mental health centers have done to be a part of that inventory and a part of this bill. You would have received from Cam earlier today, and some of you who are on Finance Committee received a copy of this a few weeks ago. What the community mental health centers have been doing for a number of years is reflected in a chart that you see here, which is trying to inventory the vacancies that exist at community mental health centers. These range from 270 to 340, depending on the month. You'll see there was a little dip in it when the 3.1% rate increases came in and some federal COVID dollars. But meanwhile, for all the right reasons, the legislature has enacted new programs, mobile crisis rapid response, which requires more personnel. Also, working in the last budget, each community mental health center opened up 6 community beds, bringing 6 community beds to the system, but that required additional staffing as well. So that's what's reflected in the first part of it, which is kind of getting an assessment of what the need is, and then how do we match that need to the workforce. Work was done, and it's in here, to take a look at the wage schedules at the community mental health centers, use information from the Bureau of Labor Statistics to determine what the shortfalls were in similar positions in the healthcare industry in northern New England, to determine what that wage gap is. And what you have in this memo, and you will continue to hear from community mental health centers, is that it's probably about a $28 million a year gap in the wages that are paid versus what the market would indicate should be those wages. So that number informed the $145 million general fund investment, which would translate into a $300 million Medicaid investment. And it's that type of analysis we think we have all of us who are working together need to bring to the legislature. We can't pick a number out of the sky. We have to justify it. But again, it gets back to what I said at the beginning. It's about ensuring that there is access. Frankly, I'm very optimistic that we're going to be able to make significant gains in strengthening the infrastructure. None of the proposals in here are asking to create anything new. These are about investing in the programs that we have now. So I'm happy to answer any questions the committee might have now, and would intend to keep you informed about the developments around the inventory of need that's underway.
Thank you. Any questions from the committee? Seeing none, thank you.
Okay, thank you.
Holly Stevens?
Good morning, Chair Birdsall, members of the committee. My name is Holly Stevens, and I'm the Director of Public Policy at NAMI, New Hampshire. NAMI is a grassroots nonprofit organization whose mission is to improve the lives of all people impacted by mental illness and suicide through support, education, and advocacy. And I'm here today to speak in support of, kind of forgot the Senate Bill 86. It's been waiting a while. I'll try to make this quick, and I wasn't able to hear a lot of the testimony when I was out in the hallway, but I don't think I'm going to repeat anything. in my written testimony, there's a lot of statistics about mental illness in New Hampshire. I'm not going to read those to you. I think you've heard them from me all before. But I did want to call your attention to the fact that because of the low Medicaid rates, we do have an equity issue in our state. And that is where we've heard from folks who call our information and resource line indicate that they have Medicaid as their payer. And they've been told that providers have a cap on the number of Medicaid patients that they're able to take, and that they have to have a mix with commercial payers and Medicaid patients in order to be able to even cover costs. And in that end, I wanted to just tell you my story about transcranial magnetic stimulation, or TMS. That is a cutting edge treatment for depression that is very costly. And what they basically do is it's the same thing as MRI, but it's a machine that sends magnetic impulses into your brain. And my understanding is it changes the neural pathways and treats the depression. And it's for folks who have failed usually on antidepressants first. And when I started receiving this treatment, what I found out was there was a wait list at the center for Medicaid patients, but not for commercially insured patients. They had stopped taking Medicaid patients because the cost to run the machine and the cost of the training because they have to have special staff in order to be able to run the machine. It's very technical, is very costly. And the Medicaid reimbursement rate for this service is so low that they could only serve a certain number of Medicaid patients. They, since this particular center have grant money, they were able to lift the restriction on the number of Medicaid patients they take, which is wonderful. But I felt very fortunate that I fell on the right side of that equation and was able to receive the treatment when folks in our Medicaid program cannot. And, you know, here today encouraging the committee to really consider raising Medicaid rates for the providers, because it's not only about hiring folks, it's about, you know, this equity issue between how many Medicaid patients are able to be served versus how many commercially insured patients are able to be served, and really addressing that equity issue that we've seen in our membership at NAMI and the folks that call us, as well as myself. So the only way to address this equity issue is by raising Medicaid rates. So because of that reason, NAMI New Hampshire is in strong support of Senate Bill 86, and I will answer any questions that you have.
Thank you. Nicely done. Any questions from the committee? Seeing none, thank you.
Thank you.
Ryan Donnelly. Welcome.
Thank you. Hello, thank you. My name is Ryan Donnelly. I'm an advocacy coordinator with Granite State Independent Living. GSIL is a statewide nonprofit organization that advocates and provides services for seniors and people with disabilities who wish to remain independent in their homes and communities. I'm speaking to you today in support of SB 86. Much has been said about the healthcare workforce crisis that New Hampshire is currently facing. It is an issue that is impacting every sector of our healthcare system. Of particular importance to GSIL and our consumers is how this crisis has affected home and community-based services. As part of our mission, GSIL provides consumer-directed personal care services to those we serve. These services allow seniors and people with disabilities to receive in-home care from individuals they choose and hire themselves, which in turn allows them to live independently in the comfort of their own homes and communities. However, as pointed out within the language of SB 86, there has been a long-term lack of investment in New Hampshire's healthcare system for many long years, including investments in home and community-based services. As Medicaid reimbursement rates have routinely failed to keep pace with recent cost of living increases, it has grown more and more difficult for our consumers to hire and retain an adequate workforce of caregivers. The daily care that our attendant care workers provide is vital to the personal well-being of our consumers, with tasks that include such things as preparing meals, showering and grooming, getting dressed for the day, or even something as basic as helping a consumer to get out of bed in the morning. A few of our consumers have even made or are considering making the very undesirable decision to move into nursing homes to get the personal care they need to live safely, because it has become too difficult to hire and retain home care workers. As a person who was born with osteogenesis imperfecta, a severe physical disability that restricts my mobility and causes my bones to break and fracture easily, I have come to rely upon this very personal care program to meet my daily needs. I am personally fortunate to have a small stable of workers that I have known for a very long time and provide care for me every day of the week. But finding additional workers or someone else to take their place would be extremely challenging. In summary, while there is certainly plenty more work to be done on this front, SB 86 will help to rectify this issue by mandating critically necessary Medicaid reimbursement rate increases. It represents an important step toward addressing the healthcare workforce crisis impacting our state. GSIL hopes the members of this committee will choose to support SB 86. Thank you for the opportunity to speak to you today.
Thank you, Ryan. Any questions from the committee? Seeing none, thank you.
Thank you.
Emily Johnson,
I have written copies of my testimony for the committee as well.
thank you.
Thank you.
Welcome.
Thank you, Madam Chair, members of the committee. Emily Johnson, I'm here with Granite Case Management, testifying today partly because Carolyn Virtue wasn't able to be here. But I will be brief. We do support the increase for the Medicaid provider rates that are contained in this bill. There are some portions of the bill, however, relating to the community health workers that we find problematic and just wanted to bring those to your attention. We object to the language in the bill that authorizes community health workers to provide individuals with care coordination. Authorizing community health workers to provide care coordination would essentially allow them to operate as case managers without the requisite license. So if community health workers are providing case management services in New Hampshire, then they would need to be licensed. And for that reason, we would ask that the term care coordination be removed from the bill. So the other concern that we do have is that there's no code designated by CMS for community health worker. And as we know, a code designated by CMS is required to bill Medicaid. So other states that provide for community health workers require them to be working underneath a physician's practice or other licensed health organization. So this allows for community health worker services to be billed for as patient education by a medical provider. Under SB 86, community health workers may be licensed independently as individuals and work autonomously. So, however, there would be no way to bill for these autonomous services. So it would also be our recommendation that language be added to SB 86 requiring the services of community health workers to be provided under the auspices of physician's practice or licensed health organizations so that the services can be billed for appropriately. And that's what I have. I'm happy to take questions.
Senator Broadley.
So I'm assuming you are referring to the new chapter, section 5.
Yes.
Okay. There's been no testimony about that so far. I was going to ask the sponsor why it's in the bill. It seems counterproductive to the balance of the bill.
Right.
Senator Avar, did you have a question?
Stole my thunder.
Sorry. All right, any other questions from the committee? Seeing none, thank you.
Thank you.
Michael Auerbach from the Dental Association. Welcome.
Thank you, Madam Chair, and through you to the members. I unfortunately will not be saying anything that you haven't heard coming from dental, but for the record, my name is Michael Auerbach. I'm the Executive Director of the New Hampshire Dental Society. I'm testifying today on behalf of, in support of SB 86. The New Hampshire Dental Society, as many of you know, is a statewide professional organization representing over 1,100 members of the dental community, including dentists, dental hygienists, assistants, and dental practice managers. Our mission is to advocate for the practice of dentistry and the advancement of the oral health of the public. And as we've discussed many times in this committee, those two concepts are not mutually exclusive. As many of you know, the NHDS, working with a bipartisan coalition of House and Senate leaders, including many of you here, along with a wide range of oral health stakeholders, has consistently advocated to create an adult dental Medicaid benefit, which the governor signed into law just last July. Dentist input in this process has been and continues to be a essential element, as it casts a light on a number of issues that have frequently hampered dentist participation in the children's benefit. In addition to low reimbursement rates, dentists in New Hampshire have overwhelmingly identified the lack of care coordination, especially in vulnerable populations, as the greatest impediments to participation. This bill recognizes this important issue by focusing on the establishment of a certification program for community health workers. It is our hope that community health workers, alongside community dental health coordinators, who are a part of the new adult benefit, will help facilitate integrated oral health and public and primary health. Furthermore, this bill takes the bold but essential step of increasing Medicaid reimbursement rates. As I mentioned earlier, low reimbursements, sometimes 30 to 40 cents on the dollar, is a major obstacle to dentist participation in the current children's benefit. Few of our states' remaining FQHCs can see new patients in a timely manner, which means that private practices are being asked to help see the surge in Medicaid and Medicaid eligible patient demand caused by the pandemic. However, all practice modalities are being asked to help in this regard, but we're experiencing a serious shortage of workforce, of hygienists, assistants, and office staff that lengthen wait times, especially for new patients. The current fee schedule for the children's benefit, as well as the expected fee schedule for the adult benefit, is woefully inadequate to help dentists pay their staff to meet patient demand. Without a significant investment in Medicaid reimbursement and dental workforce, we will continue to see these issues persist. We would like to thank each member of this committee for their careful consideration of this important bill. The NHDS believes that SB 86 FN is another important step forward to providing care coordination, investing in oral health care workforce, and serving our patients. I therefore ask that you vote it ought to pass, and I'll be happy to take any questions.
Thank you, Michael. Any questions from the committee? Seeing none.
Thank you.
Okay, so far our last speaker, and I apologize, I don't know, is, I can't read the writing. Is it Yvette Ann Vale?
Oh, Yvette Arroyo. She's a community health worker. Hold on.
And if anyone is wondering, we will not be execing this today.
Sorry?
Welcome.
Good morning. So I'm Yvette Arroyo. I work for Lamprey Health. I started as a CHW. Now I supervise 5 CHW. I want to talk a little bit about why it is important to have CHW in the state of New Hampshire. I made something briefly. I know this can go on and on and on, but I just want to, get to the point. So community health workers are important because they are the bridge between healthcare providers and communities. They can educate the community to learn about benefits they qualify for. CHW connect families to resources such as health insurance, prenatal care, transportation, legal assistance, food resources, and many more resources that these families are not aware of. Many of these families comes from different countries, not knowing the language, not knowing what services they qualify for. Most of them are even afraid of asking for assistance because of the language barrier. Now, this is when CHW meet with this family. They speak their own language. Now, this family feels safe, secure, because they can explain to the community health worker what are their needs without anyone judging them. CHW can advocate, communicate, evaluate, and navigate, and even educate the community. They can educate individuals and communities about how to use health and social services system, including understanding how the system operates. CHW can assist these families making referrals, setting up appointments, and providing follow-up. They also can facilitate transportation for these families. Myself, being Hispanic, I can relate to the community. When I came in here back like 23 years ago, I didn't know the language. I didn't know what resources were out there for me. So I struggled a little bit. I didn't have that support. And right now I feel that, this is so important for New Hampshire to have the clinic, the schools. They're there for these families that don't know what they can qualify for. Or what services they can get. And I just want to end, this saying that I believe CHW are so essential in the community. And I have to say, too, that they are the voices of the community. Thank you.
Thank you, Yvette. Any questions from my committee? Seeing none, thank you.
Thank you.
Yvette was the last speaker that I have down here. Is there anyone else that would like to speak? Yes,
Sorry, I did sign in, so I don't know if there's another sheet.
and your name?
Paula Smith.
You signed in support, but you didn't say whether you wanted to speak.
So sorry.
Come on up.
Thank you. Not something I normally do. Thank you for your time today. My name is Paula Smith. I'm the director of the Southern New Hampshire Area Health Education Center, and I also represent the Seacoast Public Health Network. I'm speaking on behalf of 2 programs. One is the Community Health Worker Program, and Yvette did a great job of talking about the need for community health workers. When we think about the healthcare system in the United States, we spend an inordinate amount of money on our acute healthcare system, but we don't really focus on preventive and managing chronic disease. Community health workers really play a key role in helping advance the social determinants of health, which really make up 80% of our healthcare outcomes. Many community health workers in New Hampshire work at different health systems, federally qualified health centers, public health networks, health departments, and family resource centers. So they're all throughout the state. Between the Northern New Hampshire AHEC and the Southern New Hampshire AHEC, we have trained over 300 community health workers in the past 10 years. I myself have been working on issues related to community health workers since 2005. And I believe that they are really an integral part of the healthcare team. So I support CHW certification. There are core competencies for community health workers that are nationally recognized, and these will be incorporated into our certification process. But this will assert the ability to sustain the CHW workforce on an ongoing basis. Right now, many community health workers are funded only by soft money, which is grants, and when those go away, the community health workers are often let go and have to find other employment. The other thing I wanted to share was in support of the nurse practitioner residency program. I have managed the residency program at Lamprey Health Care since 2017. We have graduated more than 26 nurse practitioners from the program. People who join the fellowship, there are nurse practitioners and they're licensed that come out of school, but they're new nurse practitioners. And as Stephanie mentioned, the acuity and the disease burden that people are experiencing are really hard for new grads. One of our fellows that's currently still employed at Lamprey Health Care, she shared that in her cohort, she had a close group of 5 nurse practitioners who graduated. 2 of them were part of a fellowship, and the other 3 went into primary care with no support. Those 3 individuals no longer work either as nurse practitioners or in primary care, but the 2 who were in fellowships are still retained and working in their residency related programs. So I want to reinforce that transition between the education and serving the community, the ability to ramp up people and provide them with the precepted and mentored support so that they can learn at their own pace to take care of our populations is really a crucial part of our workforce pipeline. So I'm happy to answer any questions.
Thank you, Paula. Any questions from the committee? Seeing none?
Thank you.
That is all the speakers I have. Is there anyone in the audience that would like to speak that has not been given the opportunity? Henry, I think, can you come on up? Senator Bradley has a question. And I also have you down as speaking a second time. Is that?
I can see that John had signed me in earlier.
Okay. Welcome back.
Thank you.
So, thank you very much, Henry. I think it would be helpful to committee members as well as helpful to the budget process when this bill moves along. If there's further delineation of how the funding called for in section 7 is going to be spent, that's the training dollars, I guess, to put it in that way. And also then in section 8, when we did a Medicaid rate increase, I think it was in 2019 in the budget, it was across the board. You know, I don't want to pit Peter against Paul, but, you know, between this bill and Senate Bill 36, we've heard about the need for DD rate increases, long-term care, CFI, behavioral health. I suspect there are others, but some sort of definition as to, you know, where we're going, I guess, and it would be helpful. And I think this committee should weigh in on it prior to, you know, the next step in the process. So it's not really a question, more a request.
Sure. If I could comment, if that's okay. I think in terms of how we've approached ambulances recently and what I see CMS in conversations with other states in terms of Medicaid programs, benchmarking where it's possible to do so against Medicare rates as a percentage. So, you know, it's some range of, you know, we got up to 50% of Medicare for ambulance. I'm not sure that's where we want to land ultimately, but I think that what I've been seeing, 60, 80, you know, 100% of Medicare is the highest you can pay, if you will, generally. And so I think it's somewhere in that 60 to 100 kind of range in terms of doing some analytics as to where things would stand. You know, one service may be okay at some percentage that's less than another one, but I think that's probably a good approach to be able to give you something to a reference point.
Okay. Great.
Seeing none. Thanks, Henry, for
Thank
coming
you.
back up.
Appreciate it.
With that, I'm going to close the hearing on Senate Bill 86, and I'm going,
Got to wait for a few minutes.
can I just give the committee a 3-minute break?
Obviously.
All right.
Thank you for that.
Huh?
Here.
Yeah. Let's get the tremolo. Apparently doesn't
Thank you. For the record, Cindy Rosenwald, State Senator for District 13. I'm here to introduce Senate Bill 178, which will exempt specialty formulas from the Medicaid in and out program. This program is a part of Medicaid for some adults with disabilities whose income is slightly above the allowed amount. They're required to spend a certain amount each month on medical care before Medicaid kicks in. This bill is a request that came in through the Rare Disease Advisory Council, of which I'm a member. Specialty formulas, which are more technically called enteral formulas, are used for individuals with certain congenital metabolic conditions. Eating regular foods would risk brain damage or death. These formulas are incredibly expensive, as high as $25,000 a year. While they're covered like prescription drugs for children, they're subject to the monthly spend down for adults, unlike the prescription drug benefit for adults. This bill would cover just a small number of adults in New Hampshire. We've included an appropriation to cover the cost. The department's here to answer specific questions, as is the individual who asked us to file the bill. Thank you, Madam Chair.
Thank you, Senator. Any questions from the committee?
Quick clarification.
Senator Whitley.
So just to clarify, we had spoken about this before, but it's important, I think, for the committee to know how this does or does not apply to children.
Does not.
Okay, and that's because?
Medicaid covers them for children. And I think Henry is here.
Under EPSDT? He's nodding. For the record,
Yes.
Cameron. For the record, Cameron.
Under
Director Littman is saying that it is covered for children under EPSDT.
early periodic testing and screening, something. Yeah.
All right. Thank you, Senator. Henry? Welcome back. Third time's a charm.
Yeah. Morning again, for the record, Henry Littman. We had a conversation with the sponsor. I understand the intent of the bill. Our subject matter expert on this is on vacation this week. We have a reach out to CMS to understand how this fits in with the qualifications for in and out Medicaid. As I think some of you may know, under in and out Medicaid, it's in and out means that this is an eligibility group where they have to incur certain medical costs in order to gain coverage. So what we want to make sure is that what we have in the legislation technically works the way it's intended, which is not to exclude a cost, which would make it harder to qualify, but to make it easier for them to get the coverage that they're looking for. So we'll need to come back with you. CMS is quite out straight right now with managing the end of continuous coverage, but we have made the request much before coming here. We just have not got an answer yet, and we'll certainly provide any advice and counsel to the sponsor to address this further if need be.
Thank you, Henry. Any questions from the? All right.
Thank you.
Tracy Williams, welcome.
Good morning. Good morning, Madam Chairwoman, Honorable Vice Chair, and other esteemed members of the Senate Committee for Health and Human Services. My name is Tracy Emerson Williams. I was born in Portsmouth, and I'm a proud resident of Northampton. Graduated from the Northampton Elementary School and Winnicott High School, class of 1981. After graduating from Winnicott, I earned my BS in Computer Information Systems and AS in Management, and for the past 40 years, I've been specializing in state government IT systems. I've led the IT departments in Rhode Island for both the judiciary and the executive branch. And for the past few years, I've served the Commonwealth of Massachusetts working at Mass IT, and then the state of Vermont in their Medicaid program. I'm very, very pleased to report that I'm finally here in my home state of New Hampshire. I work for DOIT, and I am the New Hampshire Cybersecurity, State and Local Cybersecurity Program Manager. But I'm here for myself as a citizen of New Hampshire. So most importantly, I'm a wife, a mother, and a junior mom to a sibling with a rare genetic metabolic disorder called phenylketonuria, or PKU. This disorder affects my little brother's metabolic system, and his body is unable to break down the amino acid called phenylalanine contained in protein. Due to this disorder, phenylalanine builds up in his brain and has caused him to be disabled. And I'm his authorized agent. My brother was born in Exeter, New Hampshire. He's a patient of the genetic clinic at the Massachusetts General Hospital, and part of his treatment plan is to take a very expensive special medication called Kuvan and to eat a low-protein diet. In order to manage the PKU, he's been prescribed a special formula. It comes in a juice box, and special medical food that has the amino acid phenylalanine removed. Because he is covered by both Medicare and New Hampshire Medicaid, his Kuvan, which is that special medical powder that he takes, is covered by Medicare, but he is unable to access the metabolic food and formula through his New Hampshire Medicaid coverage due to the spend down requirements of the In-N-Out program. And I'm really quite surprised how any policy decision maker is able to compute that a $600 a month spend down requirement when his total monthly disability is $1,400 a month is even feasible. Medicare is funding his Kuvan, which costs approximately $50,000 a month, and yet he is unable to access the special formula in foods referenced in Senate Bill 178. I learned math in the 4th grade at Northampton Elementary. They did a great job, but this math doesn't add up. And as we say here in New Hampshire, it's penny wise but pound foolish. Senator Rosenwald's bill would allow New Hampshire Medicaid members with rare metabolic disorders access to the critical prescribed formulas in food they need to live as healthy as possible, which is an economic benefit to us all. I ask you to please support this bill and to ensure that New Hampshireites with rare metabolic disorders have access to whatever they need to live as long as possible. Thank you for listening, and I'm available for any questions.
Thank you. Any questions from the committee? Seeing none, thank you.
Great. Thank you so much.
Tracy was the last person to want to speak. Is there anyone here that would like to speak that has not been given the opportunity? With that, I will end the Senate Bill 178 hearing.
These guys could be worse. It could be worse. I know.
All right, I will open the hearing on Senate Bill 170 and welcome the prime sponsor, Senator Perkins Coca. Welcome.
Thank you, Chairwoman and members of the committee. For the record, I am Senator Rebecca Perkins Coca from District 21, representing Portsmouth and several surrounding communities, here to introduce SB 170, legislation to increase the childcare capacity in New Hampshire. SB 170 would create a new regulatory category of daycare that allows licensing for up to 12 children outside of a residential setting. In listening to our small businesses and childcare providers, they said finding a location to start a new childcare business was the biggest barrier, and this bill is responsive to that need. In addition, SB 170 clarifies the law to be consistent with the fire code regulation concerning the presence of school-aged children on site at a licensed facility. We understand this to be a needed change the fire marshal can speak to, and we also have made their office aware of the concerns raised concerning this provision, and their office is going to address some solutions related to school-aged children. SB 170 is the result of a collaborative working group that included providers, the child care licensing unit at DHHS, and the fire marshal's office. This group met throughout the fall to hone the language that is before you today. Prior to COVID-19, or following COVID-19, there are approximately 36,000 licensed child care spots available for children under 6, accounting for only 60% of our children in state. Currently, 46% of people live in child care deserts where there are 3 children waiting for every one available space. This bill introduces a critical solution by providing child care opportunities to 29% more children, freeing up parents to join the workforce. This style of small group daycare also provides the flexibility and enrollment that is typical of a home-based daycare. As a mother to a 1.5 and 3.5-year-old, I live daily the challenge of fulfilling all your obligations to employers and others while making sure your children are in a healthy and safe environment. As we continue working to attract and retain a younger workforce here in New Hampshire, legislation like this is crucial. With bipartisan support and no fiscal impact, this bill is a positive step forward, better supporting our working families. Lastly, we remain open if the information presented here today concerning school-aged children does not fully address the issue, to working with anyone here to find solutions that support all of our families and providers. I urge you to vote to pass on the bill, and I'm happy to take any questions.
Any questions from the committee? See none?
Oh, sorry.
Thank
you. Sorry, Regina. I thank you, Madam Chair, and thank you for taking my question. You know, these conversations are so important. You know, as you have, I have a 9-year-old, and we've experienced childcare difficulties from day one. You know, my son actually didn't even have after-school care until 2nd grade, right? It's a big issue. We were lucky early when he was born that my mom was available for childcare. So this is a real issue up and down the spectrum, socioeconomic. I'm wondering if you can speak to, how this issue is impacting, women coming out of the pandemic, especially.
Yeah, thank you, Senator Whitley. I think we all know that women have borne sort of the disproportionate impact of the pandemic, and I know, there are more women that stayed home to take care of their children than men during the pandemic. And so what we need here in New Hampshire to keep our economy thriving is we need everyone who wishes to return to work to have that full option. And so I know on the Seacoast, we have many child care centers. People get on multiple wait lists, and, they're kind of waiting as their baby ages to know when they're going to fully be able to return to work. And I think that's a similar situation throughout the state. So please know this is the workforce behind our workforce, and that we're all just trying to respond to our businesses and what they need for our state.
What is a progressive school?
What do you mean a progressive school? Let's look.
Line 12.
Okay.
Development disabled and progressive school. I haven't heard that term before.
Small group child daycare. Whether or not the service is known, I think that it is just. I actually don't know, but it is a name for a type of daycare, and maybe there's someone here who can speak more knowledgeably to me than that. But I think it's intended that essentially this is just broadly inclusive of all types of schools.
Thank you. I just never seen that term before.
Yeah, actually, I've never either.
Thank you.
Okay.
Thank you, Senator.
All right. Thank you very much, committee.
Just have a question for Sean Toomey. You have here supporting, but you don't say whether you're speaking or not. Did you have an intention of? Sure.
Good morning. My name is Sean Toomey. I'm the state fire marshal. I was hoping to be kind of quiet, but the senator kind of, yeah, right. So as the senator mentioned in her introduction, our office has been working with DHHS and some of the other interested parties in the childcare system over the last several months to try to figure out how to make sure the alignment of the state fire code and the health and human services rules line up well, so that there's good access to the to childcare. As a parent myself of two boys, it is a challenge sometimes. This morning we saw the Boys and Girls Club program open up, and my wife said to my wife, leaving, we got to get in. So I think there is a little bit of concern still out there, I think, about the numbers. There's the staff to client ratio. So the say the teacher and the child ratios are a little bit of still some work in progress. I think the intent of this bill being to be fully effective till June of 24 gives us plenty of time to make sure that any of those modifications are addressed. There was about a 20-year-old document that came out of our office that talks and provides some support on matching the ratios to DHHS and the state fire code, and that's kind of been what the guiding document has been for the last many years. I also believe that our current code, which we have been in effect since July, the 2018 fire code, has some mechanisms in place to adjust the ratios as needed. So I think we're in really good shape, supportive of what we've done and the work we've done so far, and we'll continue to work with all the interesting stakeholders to make sure that anything is addressed as we move forward. So happy to answer any questions.
Any questions? I do have one. So is this a recommendation from the state fire marshal?
Is the original bill?
Yep.
It did not come for us originally. It came, I believe, it came from the child care community and DHHS, but it didn't come originally from us. We were asked to participate in the process, and we did happily. And
Okay.
so we've been working with them closely for the last several months.
Thank you.
Yep, you're welcome. Thank you.
Melissa Clement, DHHS. Welcome.
Thank you, Madam Chair. For the record, my name is Melissa Clement, and I'm the Chief of the Child Care Licensing Unit. And Madam Chair, I can help address where this originated from. Last session, there was a bill that was being heard on childcare issues, and this proposal was brought forth as an amendment that we knew we needed to have the State Fire Marshal's Office support on before it could move forward from the constituents. So we instead of having that amendment move forward last year, we took a step back so we could work together so we could bring it forth this year, and we've been working on it since then. But it did come from a constituent and through that amendment process. So I am here to share with you the DHHS's intention, well, not intention, but thoughts on the bill and how it impacts us, and then also answer any questions that you have about the bill. The legislation creates a new category for childcare for up to 12 children that's in a location other than a provider's home. We will be developing rules as a result if this passes for that type of category of care, so that is specific to the needs of a small childcare center setting in a setting that is not a childcare provider's home. The way our rules are and statutes are currently laid out for types of care, we don't have a separate category for a small center that is 12 or fewer children. So this type of program fits into the life safety code that has different requirements than a center that has 13 or more. So it's a little bit easier sometimes to set something like that up, but it's not necessarily economically feasible to have a center like that outside of your home for that few children. So we're trying to find ways to make a setting like that work, because we know that there is a need in New Hampshire to have more smaller centers that are located throughout the state, because there's just not enough of a population in certain parts to support larger centers, either because of the workforce or for other reasons. So we're trying to help have that category for our providers. In addition, going through this process, the legislation aligns the statute with the life safety codes as discussed previously from Senator, not Senator, sorry, Sean Toomey. Sorry about that. So for that, that's what we're looking to do. So once we identified that we needed to have a separate category of care for a small center, we realized that also that the family child care definitions in statute are not in alignment with the life safety code, so therefore we are bringing them into alignment. For family daycare homes, which currently care for 7 to 9 children, that is above the 6 that is allowed in the life safety code, but that is what's permitted currently in statute. By reducing it to 6, we've identified that there are 45 programs that will be affected by this change. And we propose that the childcare licensing will just automatically change their program type to a family group daycare for a maximum of 9 children, so they can continue caring for the school-age children as currently permitted in our rule and as allowed that with the agreement that we have with the life safety code with our current ratios. So there won't be an impact to the provider themselves, because that is something this childcare licensing unit will be just doing automatically. There will not be something in addition that they will need to do. For family group daycare homes that are caring for more than 12 children, we will work with those programs if any waivers are needed, because we have the ability to waive certain rules, and we'll do that in conjunction with the state fire marshal's office to ensure that we are it meets the life safety code, and it still allows them to care as they have been for the 12 children plus 5 additional 5 different school-age children. Currently, there are 38 programs that would be affected by this change. The fire departments locally inspect programs based on the number and ages of children in care, and therefore these programs already have the approval as required under the life safety code, because the locals would be inspecting their programs based on the life safety code for the number of children in care. So how it's being defined in statute under the childcare regulations does not impact how they are inspected by the local fire departments. This is just creating alignment in the terms. So do you have any additional questions based on my testimony so far?
Do you have a question?
Yeah, just
Go ahead.
any updates on the fiscal note?
I do not have that yet. We're working on it. I will. That would be their question.
Thank you.
Sure. We don't anticipate a fiscal impact on the childcare licensing unit side, because even if additional programs are created, at the moment we feel we have a workforce that's capable of providing those inspections. So we don't have it, but there may be other provisions that is being talked about.
I do have a question. I think earlier in your testimony, you stated that it would not affect home daycare.
For the family daycare, so in current statute, they're allowed 6 children, preschool children, and then 3 children that attend school age programs, so they're school age children. The statute is changing them from that 6 plus 3 to just 6. However, there is the other statute that is a family group childcare home, which allows for up to 12 children. So we would move those that are in the family childcare category into the family group category. We would change their license type to be family group so that they could have those additional 3 that they currently have.
Now, is that going to be a cost?
No, it's just, we're going to do that on our end. We're going to change their type, issue them new licenses.
Great.
Yeah, no
All right.
cost.
Thank you.
Seeing no other questions? Thank you.
Sure, thank you.
Thank you, Madam Chair. Committee, thank you for the opportunity to speak. I am John Randolph, owner of Harmony Homes Assisted Living in Durham, New Hampshire. We currently have a staff of about 90. As with most companies in New Hampshire, we've worked very hard the last few years to maintain our staff and necessary to keep our business open. We ask our staff on a regular basis what are their challenges day to day, and repeatedly and overwhelmingly we get the affordability and the availability of housing and childcare as the number one and number two answers. This is why we decided as a company to build affordable housing and start our own on-site childcare. But when we started to look into what it would take to have our own on-site childcare, we found that the current rules and regulations are extremely rigid and almost stopped us from being able to open our on-site childcare. We totally understand that the childcare needs oversight, clear oversight, but the state of New Hampshire needs more affordable childcare. And in order to do that, we're going to have to be more creative on how we provide this childcare. The Department of Health and Human Services needs more flexibility in how a childcare can be licensed. Affordability and availability of childcare is would be essential to allowing single parents and households of making $15 to $22 an hour to return to work. We have been able to add staff because we have started an on-site childcare and has helped us stabilize our workforce. Thank you for the opportunity to speak on this matter.
Thank you, Jen.
Thank you, Madam
Senator
Chair.
Whitley.
It's a comment, and I just wanted to say thank you as a New Hampshire business for investing in our workforce and particularly in our younger workforce. I just want to thank you for that.
Thank you.
Okay. Jennifer? Welcome.
Got it. I'm here. Good morning. My name is Jennifer Legere, and I own a place to grow in Brentwood. I live in Exeter, and I'm working with Senator Quokka on this bill. And I'm asking you to support our bill with a recommendation of ought to pass. I began writing SB 170 last year in response to a gap I found in childcare licensing rules and fire codes that could provide an opportunity to create a new category for childcare. John Randolph from Harmony Homes already provided his testimony regarding that experience for licensing his center. I worked collaboratively drafting the bill language with Melissa Clement of Childcare Licensing, Mitch Cady from the Fire Marshal's Office, building inspectors, architects, and many other stakeholders in the childcare community. The bill as presented would not only preserve the existing capacity in licensed family care, but will serve to create a new opportunity to increase capacity for childcare in New Hampshire through the creation of small centers by adding childcare opportunities for 12 children in each of the new centers created. The small centers that will be created out of the adoption of this bill will be beneficial in workforce housing units, rural areas, the hospitality industry, and for businesses like Harmony Homes and Carriage Hill Assisted Living. This bill does not intend to impact the provision of care for school-aged childcare in the homes of family care providers, as childcare licensing and the Fire Marshal's Office will testify, or have already testified, that this will be clarified as part of licensing rules. I recognize the absolute need to preserve every childcare space we have in the state and the need to provide opportunities for growth, as there are over 2,000 children, at least, these are pre-COVID numbers. Over 2,000 children we are unable to serve currently, which means 29% of our workforce is unable to return to work. I'm asking that you support SB 170 with a recommendation of ought to pass. Please accept this written testimony and talking points for your consideration. Any
Thank you,
questions?
Jennifer. Any questions from the committee? Seeing none? Thank you.
Thank you.
Jackie Cowell? Oh. Okay. Mary Ann?
Hi, I'm Marian Barter. I'm the Executive Director at Merrimack Valley Daycare Service. I'm also the Chair of the New Hampshire Child Care Advisory Council. I'm neutral on this bill, but I do have a couple of concerns. My first concern is ensuring that we do keep school-age children in family child care, that this change is happening, and the idea that for children in the past who have gone to family child care, family group child care, that they would have to get a waiver. Those programs would have to get a waiver to continue. That's worrisome. I appreciate Melissa Clement and the Bureau of Child Care Licensing's commitment to family child care, but laws last a long time. And I cannot ensure that the next administrative lead will be as supportive of family child care in this way. The second thing I'm worried about is adding an extra layer of child care licensing. We are already burdened with one of the most incredible child care licensing books ever. And we're really a very restricted industry. We all support safety of children. We all support making sure they're raised in a healthy and happy environment. But adding another layer, adding another tier to the child care licensing regulations seems worrisome to me. It's another section that we will have to memorize and know, and I'm not sure it would benefit the industry to have that. My third concern is that it may be confusing to the consumers. So people go to family childcare for a very specific reason. People go to centers for a very specific reason, and they're often looking for two different things. Micro centers, I would feel more confident if there's some way in childcare licensing where the difference between a micro center and a childcare center and a family daycare home is described to consumers as they tour. That's my comment.
Thank you. Any questions from the committee? Seeing none.
Thank you so much.
Thank you. Rebecca?
There we go. Hi, my name is Rebecca Wojkowski. I'm the Kids Count Policy Director at New Futures. New Futures is a nonprofit, nonpartisan advocacy organization, and my role is to advocate for the health and wellness of New Hampshire's children. I'm really happy to be here today to stand in strong support of SB 170 because it is vitally important to help lessen the childcare crisis that is facing our families in New Hampshire. I want to emphasize just a couple of points that will draw home how important this bill is. Recent data shows that we have about 54,000 children under age 6 and under who have 2 working parents now, and likely those children are in need of childcare. However, we know we have about 36,000 licensed childcare slots, and we are serving about 25,000 children. So when you think about that, our childcare system cannot serve as many families as it needs to right now. That impacts, obviously, the availability of workforce and also the health and wellness of kids. New Futures often, and I've been before this committee before, to talk about the importance of early care and education as setting a strong foundation for health and wellness for kiddos. SB 170 was intentionally designed to allow low-income families to access this new category of childcare because they will be able to use childcare scholarship. When we think about the families that are missing out on childcare, we have to think about the cost of care in our state. Right now, the average cost of care for an infant in a center-based setting is about $14,000 a year. In a home care setting, that can be about $10,000 a year. When we think about what we need to do as a state, we really have to consider that all families of every socioeconomic ranges need to not only have access, but more opportunities for the choice of the type of care for their kids. SB 170 creates that missing middle for families. Most families, if you talk to them right now, they will likely tell you that they don't have a choice in the child care center that they put their kids in. They have to put their kids in a center. They go with what's available. So given the fact that we know there may be some administrative challenges or changes that we need to put into place to implement this, it really matters that we do it. We cannot serve the families that we need to within the state now, and there is an opportunity to create more capacity within our state. So with that, I would just urge the committee to vote this bill ought to pass, and I'll take any questions.
Senator Whitley.
Thank you, Madam Chair. Thank you for raising the affordability issue because I think that's an issue for all families right now, all, low income, middle income, and I'm wondering if you know what the, of a typical working parent, the proportion of their income is dedicated to childcare.
Sure. So New Futures is the Kids Count grantee for the state of New Hampshire. So we produce data books on certain issues. We've looked at the cost of childcare. So right now, on average, center-based care for one infant would take up over 37% of a single parent's median income in New Hampshire, and also over 12% of a two-family household with an annual income of $120,000 a year. You need to, we should also remember that the Federal Department of Health and Human Services says that 7% of your income should go to childcare. So right now, median cost of childcare exceeds that. So, I am presuming to some extent that this type of childcare setting would be less expensive than a center-based, maybe more expensive than home-based. But, really emphasizing that we need to have a diverse set of options for families so that they can have more choice about where they put their kids and know that they can afford it. So.
Follow up? Thank you, Madam Chair, and thanks for taking an additional question. Your answer just sort of spurred something else in my head, is this issue of parental choice. And I also experienced that, right? As I said in previous testifiers, that, oftentimes not only do you not have a choice, even the one that is sort of maybe your last choice, you're on a wait list too. So I think, your point to expanding parental choice is important because, I might be comfortable sending my kid to a family-based and someone else might be. So I'm wondering if you can expand on that parental choice question.
Yeah, I think that if we ask any working mom or working dad if they really had their first choice in care for their kids, right now you would say no. I didn't have that experience either. I was just speaking that, when I was pregnant, I went on a waiting list. I never got into any of the centers I was on a waiting list for. So that was 5 years ago. My son is 5 now. So when we think about that, being able to offer a diverse set of options for families, we should really think about how we can do that better within our state. You're welcome.
Thank you, Madam Chair. Somebody brought up some concerns about safety, licensing, and the waivers. I mean, in the idea of, making and expanding for more people to have access to this, are we potentially endangering children?
So that would be my first question, and it was, but working with both the sponsor and hearing from other advocates today, as I understand it, they have worked closely with DHHS to ensure that we're actually meeting health and safety requirements when we create this new category of care for kids. The reality is, because our system cannot take in as many kids as we need, plenty of families are relying on care that is not regulated, that is not known to us. So by creating this new category that you enable individuals to start their own business, to be licensed, to be able to take in childcare scholarship. And when we think about child abuse and neglect, when we know that kids are being cared for in a place that is safe, it is far better than assuming that they are being cared for in a place that is safe. We have to assume at this point, with the delta between how many kids we have that likely need care and what our state capacity is, that there are children that are in care settings that aren't safe because their parents don't have any other choice. While this bill doesn't address it specifically, this is often common in off-hours care. Centers-based care is wonderful, and I do not think that there's one type of care that's better than another one, but what are our parents doing that work overnight shifts, that their working hours do not align with a typical childcare center? This bill doesn't address all of those questions, but there are things we should consider when we are thinking about how do we strengthen our system in New Hampshire.
Thank you.
I do have a question, and I'm not sure it should be sent to you, but reading some of the concerns other people have, and I look in the legislation, the lines that are lined out is, in addition to the 6 children, up to 3 children attending full-day school program may be cared for up to 5 hours per day. So if you have 2 children, one is younger and is in the daycare program, and the older sibling has been in that daycare program and starts going to school, and then after school comes back, why? It sounds like they will not be allowed to, they may be given a waiver, they may not be, but why would that older sibling not be able to come back to the same daycare provider?
That question I cannot answer for you. That's better for licensing or for Jen to talk about the regulations around that.
All right, I'll
I can
bring
defer to
Melissa
them.
up at the end.
Great.
All right, any other questions? See none, thank you.
Thank you.
I think our last speaker, Dave Juvet from BIA. Welcome.
Thank you, Madam Chair, members of the committee. For the record, my name is Dave Juve. I'm a Senior Vice President for Public Policy with the Business and Industry Association. And I'm here today to convey that this is a critical issue for New Hampshire's employer community. Some of you are familiar with what the BIA does in terms of getting input from employers around the state. Every summer we hold a series of roundtables. In the summer of 2022, we held 10 different roundtables around the state. We talked to over 400 employers, small business people, medium-sized business owners, and large companies. And it was through this process that we heard about workforce housing around 2008. And it's interesting that that topic has come up a couple of times from people testifying on this bill. When it came up in our roundtables 15 years ago, frankly, staff at BIA didn't even really understand what the employers were telling us. We thought initially they were talking about low-income subsidized housing. We all know now that is not what they were talking about. They were talking about the lack of access and affordability to housing for working people, and that quickly rose to be a top concern for the BIA. The subject of childcare, interestingly, came up several years back at these roundtables, not predominantly, but it did come up. But in 2022, it came up at every single roundtable from employers of all sizes, and they recognized that this is an issue like workforce housing that has an impact on their ability to hire. We all know that employers now, one of their top concerns is their inability to find a workforce. Frankly, I've often said New Hampshire's economy is expanding faster than the ability of employers to hire people, and that accounts for our extraordinarily low unemployment rate. Employers have identified, like workforce housing, that available and affordable childcare is impacting their ability to get people into the workplace. They're doing what they can in terms of coming up with family-friendly policies like flexible work hours and things of that nature. But like workforce housing, employers are asking you folks to focus on this issue, an issue that they don't really feel that they have the ability to handle on their own. There are some employers like Mr. Randolph and others that have the ability to not only provide some employer-assisted housing, but are now looking at employer-assisted daycare for their employees. And that's fantastic, and we're fully supportive of that. But not every employer has the resources or the ability to do that. So we're turning to the state to make significant policy changes that will allow for more available and affordable childcare. That concludes my testimony. I'd be happy to try and address any questions.
Senator Whitley.
Thank you, Madam Chair, and thank you for being here today. I as a working parent myself, I just want to say that I truly appreciate the BIA's willingness to engage in this conversation and, really take a leadership role at this point in, working with families to have broader access. So I just wanted to thank you for that.
Thank you. And Senator Whitley and also Senator Perkins Quokka have been frequent guests at BIA's Workforce Development and HR Policy Committee talking about this and workforce housing. And so firsthand that this is an issue from employers that are not a part of the BIA, but also many, many employers around the state that aren't BIA members. It really is significant.
Thank you. Any other questions? Seeing none.
Thank you.
That is all the speakers that I have on my list. Is there anyone here that wants to speak that has not been given the opportunity? With that, Melissa, can you come on back? Come on down again.
Yes, thank you, Madam Chair.
So you heard my question.
If you don't mind repeating it, because there was a lot of information, I want to make sure I'm answering the
See if I can
question
remember it.
you have.
So,
remember what I said.
Yeah. I might be able to assist, but I just want to make sure I'm answering the
so
correct
my
piece to
my
it.
question is, if you have an in-home daycare provider that is taking care of 2 children,
Mhm.
a younger and an older sibling.
Okay.
And that older sibling moves on to go to school, but the younger sibling is still in the daycare, at the daycare provider. It seems like by lining out this language in line 18 and 19 and 20 and 24, that older sibling will not be able, without a waiver, that older sibling will not be able to come back in if they're in a full day school.
Right. So, the way the statute is written now, it does allow for 6 children that they have all day,
Right.
before school, and then they can have additional school-age children. With this change, anyone who is licensed as a family daycare home will move into family group. So they will have a license for up to 9 children, which can be all day, or they can plan because they have children that are in their care. They know that they're going to need that spot for school-age children. So it's as families come in, licensed childcare or the providers say, okay, I know that this child is going to be here, up and through their school, provided that this parent chooses to stay. And then I know, talking to the parents, they are going to want them to continue here after. So they will save one of those spots for that child. It's not eliminating it in the sense that their capacity is going to decrease, because as I testified before, we can move those family daycare homes into the family group and still allow them to have the 9. So they're still going to have a total of 9 children. Currently, that's what they have now. They have 6 plus 3 school age. So they're still going to have the same number of children. It's just how they manage that enrollment that'll change. For the family group, it is stopping them at 12. They don't have the +5 option, and that's when they have 2 providers with 12. We are going to be working with the state fire marshal's office with our existing rules in order to continue that, because they are being approved now through the life safety code as having 17 children. So they are already being looked at by the life safety code to have that many children. So we're going to figure out how to make that work in our waiver process, which we regularly do with programs when they are trying to provide care in a way that doesn't fit our rules the way they're written. We have a waiver process to allow for that, those changes. So I'm not sure if that clearly answers your question, but the intent of this is obviously to align it with life safety codes to make sure that we're not out of compliance with them when we're categorizing care. It changes how programs may be licensed, but it's not going to change. We don't anticipate changes that will restrict them from caring for children the way they are currently, either because of the change from family home to family group, or through our waiver process that we're able to have them continue as they are.
All right, I'll talk to you offline on this one.
Sure.
Any other questions from the committee? Seeing none. That is the last speaker for Senate Bill, thank you, 170, and I will close the hearing on 170 and give Cam a little time to get organized.
Thank you, Chairwoman, and thank you, committee. It's nice to be here with you. For the record, I have Senator Rebecca Perkins Quoker representing District 21, the city of Portsmouth, and several seacoast communities. It needn't be established that pregnancy is hard work for a woman's body, but the ways in which pregnancy takes a toll is often neglected or misunderstood. As a mom of 2 little girls, I know that sometimes the mental and physical needs of mothers often get put on the back burner. One such hidden burden is the need for pelvic floor rehabilitation. Pelvic floor physical therapy is a treatment for problems related to the pelvic floor. This specialized therapy includes exercises that can help relieve symptoms like pain, discomfort, and disruptions to your quality of life, including incontinence and the return of regular bowel function. Without this therapy, many mothers are unable to return to their full daily life and instead experience unnecessary and potentially preventable discomfort and interruption. Low rates of awareness and high stigma associated with pelvic floor disorders already complicate this entire process. Men are also afflicted by pelvic floor dysfunction, which I learned in bringing this bill, and the stigma attached to them to seek treatment also remains high. Yet when many individuals have attempted to have this therapy covered by their insurance, their claim has been denied, unfortunately, due in part or full due to the lack of injury. So SB 176FN would fix this, requiring insurance providers to cover pelvic floor therapy. This bill is bipartisan and will establish uniformity of expectations around private insurance carriers. Luckily, most of the insurance providers will say that pelvic floor therapy is already covered, which is great. The Commissioner of Insurance, in conversation with him, he also agrees that pelvic floor therapy is covered by most private carriers. Unfortunately, there still exists an issue because it is the experience of patients and providers that when they submit for reimbursement, it is often not the case that the claim returns as covered, potentially due to it being unrelated to the injury. This can happen in cases, as an example, of provider submitting a diagnosis of lower back pain might be regularly covered, whereas submitting for a diagnosis of incontinence may not be consistently covered. And so there seems to be some ambiguity in terms of how this is enforced and how it's used as a provider, unfortunately resulting in many providers not even being able to carry insurance because of the uncertainty around their sort of business being reimbursed, and thus is an impact on our patients and our newborn moms who are trying to return to work. So, I think it's important for us as legislators to make sure that we're establishing clear, concise standards for busy moms and families at a very important time in their life. And I'd also like to address something that I saw in the fiscal note when I was reviewing. And I want to clarify that the intent of this bill is not to ask for coverage for prophylactic pelvic floor therapy. So that would be therapy in advance of birth. And if there's language changes that we need to make it to ensure that the providers and the commissioner are comfortable of the scope of what we're asking for, then I'm happy to do that. But we do want to make sure that the actual injury that occurs with childbirth is fully covered by our providers. So with that, I will conclude, and I'm happy to take any questions that I can answer.
Senator Whitley.
Thank you, Madam Chair, and thank you for bringing this bill, right? This is something that a lot of women experience, they don't talk about. So even just bringing this bill, I think, addresses stigma. So what I have heard from many of my mom friends, my constituents, is that, it's so hard to find a provider. And so, you had mentioned this issue a little bit, but are you hearing from providers that, this ambiguity about coverage is the reason why, this is becoming a sort of access issue?
Yeah, I mean, unfortunately, there just seems to be sort of a lack of things being synced up. The providers and, like I said, the commissioner are saying this is covered, which again is great. There's not a substantive disagreement there, but unfortunately, the reason I'm bringing this is because it has been brought to my attention that many providers have simply given up on taking private insurance, and ultimately that really impacts our moms and our patients. And so we want to support our small businesses and them, trying to create jobs and and be able to run their practices in a sustainable way. And then I think, in turn, we want to be able to support our residents and our patients by ensuring that they have the smoothest access to care that they can.
Follow up? And have you heard from providers that the clarity that's provided in your bill, if that was in statute, that would support that business decision?
Yeah, I think it would, because they were not even aware that this was fully covered by the providers. So I think it's an important message. I think it creates an important uniformity, and I think it also avails them the ability to kind of have that conversation with the providers, both patients and providers of pelvic floor therapy will be able to have that conversation with the carriers. Yeah, thank you. All right, thank you guys very much.
Good morning, members of the committee. For the record, my name is Becky Whitley. I represent Senate District 15. The only reason why I'm testifying today is that I had a constituent who wanted to provide testimony, but she wasn't able to because she's a working mom. So I'm just here to provide her testimony, and I appreciate the committee's willingness to hear this. So this is from my constituent. Good morning, Madam Chair and members of the committee. My name is Karen Cohen, and I'm a 38-year-old woman and mother of 2 boys. Both of their births were vaginal deliveries with no major complications. I experienced moderate urinary incontinence after my firstborn. However, after the birth of my second child, the bladder leakage was much worse. My OBGYN gave basic advice for exercises. Pelvic floor therapy was mentioned, but also that insurance may or may not cover this, depending on the carrier. I decided not to pursue PT and was hopeful that the problem would resolve over time. This was not the case. Over the next 5 years, I often experienced leakage when sneezing, coughing, laughing too hard, dancing, jumping, running, all of the things parents of young boys do on a daily basis. My life was negatively impacted, and it affected my family as well. Before considering surgical options, I started pelvic floor therapy last summer. My current plan covers approximately 50% of this service toward the deductible, and I'm in a privileged position to be able to budget for this expense. I'm sharing my story as postpartum stress incontinence is common for new moms, and this issue is not often discussed. We need to improve the care and support of women and families after childbirth. If pelvic floor therapy was fully covered by my insurance, I most likely would have sought help earlier and been able to fully enjoy our post-dinner family dance parties sooner. Thank you. And that's Karen Cohen from Hopkinton.
Thank you, Senator. Any questions from the committee? Seeing none.
Thank you. Thank you, Madam Chair, members of the committee. Good to see you all again. For the record, Peter Bragdon, recovering state senator, also a senior policy advisor at Pretty Strategies, here representing Harvard Pilgrim Health Care, New Hampshire's not-for-profit health insurance company, a company founded by doctors. And here, in opposition to Senate Bill 72, I will say that Harvard Pilgrim Health Care is supportive of pelvic floor therapy. And in fact, we do cover it, as was mentioned, as I believe all the health insurance companies cover pelvic floor therapy as part of their physical therapy package of things. I think the issue we see here is not an issue of coverage. It may be an issue of education and providers maybe not knowing exactly what is needed, or the patient themselves not knowing what is needed. Generally, though, putting something into statute to cure an issue that is already being covered is not something that we're supportive of, because the statutes change relatively slowly and technology changes much faster, so sometimes can be behind the curve. We're certainly happy to participate in any efforts to educate people on this and make sure people understand. And I will say that even if you put it in statute, my understanding is there's still a medically necessary criteria. So if it's coded wrong, then it still doesn't get covered. And so I think putting it in statute doesn't necessarily solve the problem. I think this problem is solved by working with the insurance company, working with the providers to make sure people are educated that this service is available and fully covered. Happy to take any questions.
Senator Whitley.
Thank you, Madam Chair. Thanks for taking my question. So you're aware that we have other sort of insurance mandates in statute, correct?
I have heard that, yes.
Yeah. And I don't know if you're aware, but are you aware that pelvic floor therapy is specifically mentioned in statute in Maine?
No, I'm not aware of that.
Okay. Does the insurance company that you represent provide services in Maine?
Yes, they do.
Okay. Thank you.
Any other questions? Seeing none.
Thank you, Senators.
Senator. Michelle Heaton.
Hello, my name is Michelle Heaton, and I'm here on behalf of the New Hampshire Insurance Department. I'm the Health Law and Policy Legal Counsel. The Insurance Department does not take a position on this bill. We're here more for informational purposes. Some of the things I would like to highlight that other people have mentioned is we do believe this is a benefit that is already required to be covered as part of the essential health benefits, and it is something that we've heard from the carriers that is routinely covered. By putting a mandate into statute, one of the things that you all should be aware of is that there's a possibility this could be deemed a mandate of coverage that's in addition to current EHB. To the extent that it is, the state would be liable to defray any costs associated with it. So we just want to be aware of that. We also have the ability under RSA 400A 39B that if it's requested, we can do a mandate study on this to see what kind of impact it would have moving forward. So I don't want to repeat anything that anyone else has already said, but I'm happy to answer any questions.
Any questions, Senator Prentice?
Thank you. Senator Birdsdale. Aye. No, it's all good. Oh, gee, I got that. Okay, took me a minute. All right. Good morning. Thank you for coming today. And so defray costs expected that the state might have to cover those. Can you just explain these defrayed costs that we may be expected to cover? What I've heard this before, but can you just help me along?
Yeah, so there's the essential health benefits, which are categories of care in our New Hampshire benchmark plan. To the extent that the state passes any additional mandates that mandate coverage of health benefits that are beyond what is covered as an essential health benefit, the state has to pay that difference in price. Does that make sense?
It does. Yeah. Follow up? So the difference in price per patient or per year, I mean, is it handled on an individual basis?
It's not really clear. We have not had to defray anything as of yet.
Okay.
So that hasn't been done, and the guidance, the federal guidance on it isn't exactly clear, but it would likely involve an actuarial study. That's why we have that provision under 400A 39B, so that we can have actuaries that we have on contract do some analysis so we can get some kind of ballpark about what that would potentially cost the state.
Okay, I'm good for now.
Thank you, Madam Chair. You mentioned that if it's deemed as a mandate, then potentially a mandate study would be suggested so that they can figure out what?
If there's any potential of there being a mandate, this being a mandate that would require defrayal, we can do that study at any point. The legislation does not need to pass. If it is deemed by CMS to be something in addition to what's required under the EHB, the state would be required to defray those costs. And what those costs are right now is indeterminable. We have no idea, really. We would have to do additional analysis to figure out what that would be.
Right. Thank you.
Thank you, Madam Chair. So the two other sort of insurance mandates that I'm aware of in statute are ones related, it's just from my professional experience, related to children with autism, right? There was significant work done by this legislature to ensure that services for children with autism are covered by insurance companies. So that is in statute. And my understanding is that that's really expensive, right? Services. And my understanding is that the state hasn't had to defray those costs. Is that correct?
Yes. So anything that was passed as in mandates, we do have a long list of mandates in New Hampshire, but anything that was passed prior to January or enacted prior to, I think, January 1 of 2010, it's considered part of the essential health benefits. So you don't have to defray. It's any additional mandates passed after that that are beyond essential health benefits. And with respect to autism, there's also other laws that come into play. With respect to mental health is an EHB and mental health parity. And so there's a lot of different pieces that play into that.
Follow up? The other insurance mandate that I'm aware of is for fertility treatments, and that was, as you said, after the 2010 benchmark. So that would be included in what you're talking about. And so my understanding is that fertility treatments are now in statute as you described, a mandate. It's post 2010. Have there been a defrayed costs for that?
No, because that mandate is specific to the large group market, which you do not have to defray for. It is the small group and individual markets are exempt to get around the issue of defrayal.
And
So
this
it's not a
insurance
mandate in those.
follow up. Sorry, and this impacts which group market then?
This would impact both individual and group insurance.
Well, that makes it simple.
Senator Bradley.
So has the department gotten complaints from insured folks that this is
No.
not covered?
No, we are not aware of any complaints coming in. The insurance department does have a consumer protection branch to us, and we would be happy to work with anyone who has commercial insurance that this is not being covered. We would help them, navigate the system to make sure that if it is something that should be covered, it is covered for them.
And the concern, thank you, Madam Chair, the concern in the, your testimony and the fiscal note is that if this bill were to pass, and it would be a sort of a blank check on all treatments, not subject to co-payments or visitation limits or things like that, that other insurance mandates might have.
Well, the way it's, the fact that we think it is covered, but to the extent that there's anything that's not covered, that could be considered in addition to, and that would be subject to the mandate. The language does say benefits provided under this section shall not be subject to any greater copayment, deductible, or co-insurance than any other similar benefits. So if a plan were to have, a limit on the number of PT appointments, this would still be subject to that. If you still have to meet a deductible of $1,000 before, the insurance kicks in, this is still going to be subject to that. So it's not going to fix some of those kind of affordability issues. It's not going to make it, this is covered at 100% and there's no cost sharing.
Thank you, Madam Chair. That sort of spurred a thought for me also. I understand that individuals are able to make a complaint to the insurance department, but what I see in this situation, what I heard from prior testimony is that people aren't even getting to the point to request coverage because there are no providers, because providers, aren't seeking, right? So isn't it the case that, how would someone make an insurance complaint if they don't even get to that process because there's not a provider, correct?
They're required to cover the benefit. So, I mean, it's a complicated issue that there's part of it that's insurance, part of it is workforce provider issues and all of those other, general public health issues. But if it's a covered benefit and there is a provider available and willing to provide this treatment, then, the insurance would have to cover that.
Thank you.
So the issue might be the fact that people should be notified somehow that there is coverage.
I mean, that's more of a public policy issue from an insurance perspective. We think it's covered to the extent that people don't know this is covered. Maybe that is an education portion.
And that would solve everything.
I don't
Yes.
know.
I'll learn.
I mean, I don't know if that's going to solve all of the problems. I think there's a litany of issues that people have brought up here, but from the insurance perspective, we do believe that this is a covered benefit. And just as a side note, personally, not as an insurance department representative, I am pregnant. I am aware that my OBGYN does have a physical therapist that they work closely with to address issues related to gynecological obstetrics care that need physical therapy. And my husband is also in PT recently, and they have on staff someone who specializes in postpartum PT. So there, I think maybe it's an emerging field that is now, there's more awareness of it, and there are more providers becoming available.
Yeah, again, thank you, Madam Chair. Going back to the fiscal note, if it is a new benefit over and above essential health benefits, we might have to make a general fund appropriation, as I understand it. But if we were to ask the insurance department to do I guess it would be a cost estimate of the proposed mandatory coverage, how long would that take to get that kind of analysis done?
I think for this type of mandate, maybe a month or two. I'm not exactly sure. We do a contract with an outside actuarial agency that helps us do that type of analysis. And if it's something that you guys want us to do, we can look into getting that and can try to expedite it as quickly as possible.
Okay.
Thank you.
Annie Hopkins?
Thank you, Madam Chair. Hello, everyone. For the record, my name is Annie Hopkins. I am a pelvic physical therapist specializing in pregnancy and postpartum care. I appreciate you all hearing this bill today. And I would just like to start with kind of setting the scene, setting the bigger stage here of why pelvic health matters, especially in the pregnancy and postpartum periods. The U.S. has the worst maternal morbidity and mortality in the world. We have 24 deaths per 100,000 live births, which is 3 times higher than other developed countries. For example, France and Canada have 8 deaths per 100,000. Germany has 3, and we're at 24. So this really is a national crisis, and I think that, you know, my testimony today will hopefully set the scene as to why pelvic PT, adding more support, adding more qualified healthcare professionals into the pregnant and postpartum period is vital. So 52% of U.S. maternal deaths occur in the postpartum period. 21% of those deaths occur within the first 6 weeks postpartum. AHEC, the American College of Obstetrics and Gynecology, has recognized this and has updated their stance on optimizing postpartum care in 2018. And they're advocating for a visit with an OBGYN 2 to 3 weeks. I will note that while that is ideal, it's not currently the reality. People can't make it to the visit because of socioeconomic status. 1 in 4 women return to work after 2 weeks after giving birth, making them unavailable to attend that. Maternal healthcare deserts exist in the nation, and there is an overall shortage of maternal care providers relative to the number of births in the United States. This is data on a national level. 75% of these postpartum deaths are caused by hemorrhage, infection, or blood pressure conditions. And that is something that pelvic therapists can screen for. You know, it's, if you look at the home care model where we're looking at, you know, geriatric care in the home, it's routinely done by physical therapists, blood pressure checks, medication checks, depression screenings, you know, all of these things. We are qualified to help support the maternal care providers in our state in not missing out on these severe comorbidities or causes of death. Childbirth is a musculoskeletal injury, and it's not recognized as such. The changes occurred during pregnancy. You know, I'm 5 months pregnant myself. The changes are already happening. The event is pregnancy, but prophylactic care is a whole nother issue. As the body changes during pregnancy, it then drastically changes during childbirth, either vaginal birth or cesarean birth. And then the postpartum time period is also a big musculoskeletal shift and burden. We have to carry this infant. We have to feed this infant. We are sleep deprived, and these all set the stage for conditions for poor healing. Unfortunately, mothers are given currently one postpartum visit at 6 weeks. And that 6-week visit is when we are, quote, all clear to go back to whatever we would like to do. Unfortunately, this is not an adequate representation of what the mother's body is capable of. At that 6-week visit, we are looking at, or OBGYNs or midwives are looking at, did the placental wound heal? Have the stitches healed? Is the body going to hemorrhage or get a severe infection if normal activities are resumed? That is their medical perspective. That's what they are trained in. And medically, around 6 weeks, they say, nope, you're good. You could go back to exercise without hemorrhaging, and you could have intercourse again without getting an infection. Great. What our culture has decided is that that is the all clear, check, you're good to go. And that's just not the case. OBGYNs and midwives do not assess for musculoskeletal conditions like a physical therapist or even an occupational therapist would. It is our job to assess the physical readiness for people to return to work, activities. The testimony provided by Senator Whitley's constituent, very precisely captures what we're looking at. We're not looking at returning to marathon running. We're looking at, can I run with my kids? Can I jump in the bouncy house at their birthday, at their birthday party without peeing my pants? And when we look into the orthopedic world of things, surgeons and doctors are best friends with physical therapists. You wouldn't sprain your ankle and not go to PT. You wouldn't have ACL repair without going to PT. So these musculoskeletal injuries are given the respect that they deserve whenever we're in the orthopedic world. It's standard. And in the childbirth world, that injury of childbirth is not respected. And it causes injury to mothers. And with the healing, the body's healing timeframes are the same. So it's also 4 to 6 weeks for a tendon repair in the shoulder. When we look at that in that postpartum 6-week visit, we're saying, hey, did your wounds heal? Is your soft tissue okay? That's the same healing timeframe as we look for in any orthopedic injury. In orthopedics, you would go from, okay, everything's protected and healed. Now we're going into the mobility phase. We're going to get, ramp things back up. And then around 12 weeks is the return to sport phase. These are not just specific for orthopedic conditions. This is how our human body heals, period. And that healing is often guided by a physical therapist in the orthopedic world. And mothers are just left kind of out on their own. At that 6-week checkup, you're fine. Do whatever you want. But don't do too much. But it's okay. But maybe it's not. And women are just coming to me like, I don't know what to do. So then they try something. They're like, oh, well, I love running. I'll just run. And then that is where the compounding injury occurs. If childbirth was the initial injury that weakens the pelvic floor, weakens the abdominals, it's the, okay, well, I'm good to go and I really want to get back to it. Now, I have symptoms of prolapse. Now I have urinary incontinence that I didn't have before. So childbirth sets the stage for these injuries that have lasting effects in maternal health and cost a lot of healthcare dollars. Some common injuries, because this is an or a poorly understood area and it's private and shameful to talk about, I'm just going to list some of the most common injuries postpartum. So urinary incontinence is one of them, where they cannot control their bladder. Fecal incontinence is another one that can occur with 3rd and 4th degree perineal tears. So the more severe the tear, bowel function can be impacted as well. And we certainly don't talk about that because that is not something anyone wants to admit to. Prolapse, when one or more of the pelvic floor organs descends into the vaginal canal. And prolapse, the current top solution for this is surgery. They say, okay, well, call me when you need a hysterectomy. Okay, we'll just put in a bladder sling or a mesh or something like that. These surgeries have about a 40% recurrence rate. So, and it's not because we have a country of inept surgeons. We have excellent care. It's because the root of the problem wasn't addressed. And prolapse has happened because of the weakness in the pelvic floor, the poor return of core stability, and the prolonged pressure that is pushing onto these pelvic organs. So we are missing the root cause. Women are undergoing potentially unnecessary surgeries that fail over time. It's really one of the things that breaks my heart the most is prolapse. Painful sex, pelvic pain, orthopedic pains can also be mimicked by or can be caused by pelvic floor dysfunction. So back pain, hip pain, groin pain. Oh yeah, my hamstring has never been the same after childbirth, and I can't get back to doing something that I love. I've tried PT, I've tried this. We're missing the root cause. And I haven't even mentioned cesarean, which is a major abdominal surgery. And the scar tissue from the abdominal incision, scar tissue from perineal tears, all can absolutely affect function for many years to come. And I think the emergence of pelvic therapy was mentioned. And yeah, we are really trying to keep up with the demand. It is a specialized training. So for example, when I was in school in the early 2000s, pelvic therapy was not mentioned in my university programming. It's now kind of an elective in some, but this really isn't fully understood by the medical community, even by our own physical therapy community and occupational therapy. But when we look at the number of folks who would benefit from this service, in my opinion, every postpartum person. Postpartum people are forever. This is people's grandmothers and mothers and sisters and aunts. It's like not just the person who is the newborn mom. This affects people over their lifetime. And some of the, I like to look into the bigger picture here again. Up to, I think, 23% of women stop exercising because of urinary incontinence. And 60% of women with severe urinary incontinence are likely to be insufficiently active. Okay, why do we care about that? It's not just that they're losing something they love. Let's look at exercise as a role in healthcare. Exercise is key for things like preventing heart disease, things like preventing osteoporosis and bone density loss. It affects mental health and all of these things. Oh, and hip fractures. There's data that says, so each year over 300,000 older people, 65 and older, are hospitalized for hip fractures. More than 95% are caused by falling, and women experience 3/4 of all of these hip fractures. So again, when we're looking into the long-term health and the long-term healthcare costs of healing people in this postpartum window, it makes so much sense to me. An ounce of prevention is worth a pound of cure. And one of the main barriers is insurance coverage. So it is covered, but it is undercovered. So if AHEC again mentions that 75% of women will have painful sex at some point in their lifetime. This code, dyspareunia, is the name for the clinical code. So if you go to the doctor, they would get diagnosed with dyspareunia, which means painful intercourse or penetration. That code is universally denied by healthcare and insurance. It will not get reimbursed. So we have to kind of sidestep around and like pick a different code just to even get these services covered. There's also undercoverage for things like stress urinary incontinence, bowel dysfunction, because to me it just looks, it seems like whenever we see genitourinary dysfunction and a physical therapist submitting these codes, insurance just says, I don't really understand why those two go together yet. So we also get restricted visits. It's like the first visit is covered, we'll give you 2 more, and then you have to fight tooth and nail paperwork, and then you're cut off. So there's undercoverage in the reality of what this is, because it's not proven, or it's not, I don't know, the documentation required for some of this is just maddening. And then maternal care deserts. Again, that's mentioned, time and time again. There aren't as many practitioners in the state as there could be. There aren't as many maternal care providers in our country as there could be. So it's really a point that needs clarification, because there is a disconnect between insurance companies saying this is a covered service because PT is a covered service, but pelvic PT really runs into these struggles of under coverage. And, as far as being in-network, I'm an out-of-network provider, okay, because I worked at an in-network clinic. I worked at 2 in-network clinics, and one of them, the one that was purely pelvic physical therapy, had to drop all insurances because she was on the brink of going under in 2020. She's now only in network with one. And I look to my peers to say, well, I mean, my gosh, if that didn't work for you, why would it work for me? There's another solo practitioner in our state who, again, she thought maybe I'll just go in network and I'll get more business. And she had to go out of network again because of chasing the bills and filing all the paperwork. And then the reimbursement rates come, and they are low. They're too low, as I believe my friend Dr. Kristen Zames attested, that they're not, the reimbursement rates as they currently stand are not enough to support actually a small business with admin and rent and all of the costs of running a business. So it's not an attractive deal for providers, and it is a difficult service to receive as a patient. So that is my testimony. I'm not happy to answer any questions.
Thank you, Annie. Any questions? Senator Whitley.
Thank you, Madam Chair. I just, again, there's a lot of thank yous today, but, I just wanted to thank you for coming here to talk about this and for supporting our moms. Like, to me, we're talking about basic dignity. Like, there are a lot of us who are moms, right? It's a big swath of the population. And I appreciate you fighting for our basic dignity to not pee our pants. So, it sounds a little hyperbolic, but it is, to me, about basic dignity. I don't know if you agree about that.
Yes, I absolutely do. And, it's not just some urinary incontinence affects 50% of adult women and 75% of women over age 65. So it's not just some people that have these complications. It is a lot of people having these complications.
Thank you, Annie. Any other questions? Seeing none? Thank you.
Just don't want to scare you.
Hey, I signed up for this too.
Oh, yeah. It's a lot, just thinking, you're just sitting there and just listening to
A lot of insurance companies are back here. I know.
Courtney.
Despite all this, I've signed up.
Feel bad for the mom listening.
Good morning. I guess
Welcome.
it's the theme because I'm 3 months pregnant, so I guess it's the theme of the day. Yes, I did. So I will be really quick. I know I'm standing between you and lunch. Courtney Tanner, Director of Government Relations at Dartmouth Health. We provide these services. I wanted to provide some perspective in terms of the landscape of providers that do provide this service. We have GI and radiology services, particularly surgical services, in our Manchester clinic and our Lebanon clinics. We also, as you can imagine, you've heard a lot of testimony today on women's health care. We have OB pelvic floor services in Bedford, Keene, and Lebanon. And so just wanted to provide a landscape of kind of where some of these services are provided. We support the bill. We really believe the bill provides increased patient access. And I'm happy to take questions, but wanted you to know that we're probably the lead provider of many of these services in the state and support the bill.
Any questions? I do have one. Since you represent Dartmouth Health, how does Dartmouth get the word out that they are covered? Because it sounds like that's kind of the biggest issue. And how does Dartmouth get the word out that you cover these services?
So we provide services regardless of a patient's ability to pay for their services. As you can imagine, we take all types of payers, whether that's self-pay, Medicaid, group health insurance, individual insurance. So there's a referral mechanism at Dartmouth Health, but patients certainly have access, and that shouldn't be a barrier at Dartmouth.
Senator Bradley.
So have your providers at Dartmouth had problems collecting from insurers that say that they cover
I'm
these
doing some
services?
research right now, Senator, so if you can give me like a day or two, I can circle back
Day
to
or
the committee.
two you absolutely have.
I sent out the note last night.
And I'm assuming that you agree with the prior witness that basically said an ounce of prevention is.
Yeah,
worth
I'm a
a pound
mom
of
of a
cure.
3-year-old, so I'm, speaking from a personal capacity, yes, absolutely.
But I meant it more in the sense of, medical prevention is a cost-saving.
Absolutely, and I should note that our clinics are multidisciplinary clinics, and that surgery is not the jumped to option. I mean, there's PT services and other services that are provided in advance of surgery. Of course, that's the last resort.
Okay, thank you.
Thank you, Madam Chair. Just to clarify to, what Senator Bradley asked, about, like, is it correct that you're able to provide services even if it's not covered because you're such a big,
Yes.
right, so you can disperse it. Okay, thanks.
Thank you, Courtney.
Last speaker, Paula Rogers. Welcome.
Thank you, Madam Chair, and nice to see the committee this morning. It's been a long morning for you, and so I'm going to be rather brief, and I signed up neutral. And the reason was I didn't want to really support it because I have some reservations around whether this is the appropriate way to get the news out on pelvic floor disorders. And I want to say rather than therapy, the main bill, and I've forgotten who asked about that, it may have been you, Senator Whitley, the main bill uses the term pelvic floor disorders, pelvic floor disorders, because therapy is sort of a very generalized term, and the disorder sort of rolls into the basic insurance construct, which is there has to be something wrong or disordered in a way to meet the terms of medical necessity and then the ongoing treatment. But as I listen to all of the testimony, what occurs to me is, and like all people, I started Googling pelvic floor disorder, and you cannot believe the information that is online. So I don't understand why the pelvic floor disorder information doesn't also somehow gather the fact that, and it's in the insurance department's fiscal note, that it is covered. So if there's a pelvic floor issue, insurers are covering it. And the question is, well, how are they covering? Through what providers? Well, apparently there's a segment of PT providers that feel that this is a specialized segment of physical therapy, and perhaps they are not tuned into the insurance mechanisms that exist. So there was discussion in one of the speakers who spoke very committedly to the issues around pelvic floor disorder as to difficulties with insurance companies. And there are difficulties with insurance companies. There's this, there's a coding that's required that claims have to be filed appropriately on a timely basis, and the insurers are supposed to pay on a timely basis. And if they reject a claim, they're supposed to give some sort of a reason for it. And so, absent a sense that the insurers are dropping the ball, or the providers are dropping the ball, what do we do here? And I think public education is really important. One of the things I found in on the internet last night was back in 2005 at the federal level, they actually entertained a piece of legislation, which didn't go anywhere, which was a whole protocol of what to do about pelvic floor disorders and how to make it more clear that the very thing that I think Senator Bradley was trying to bring up is if you catch a disorder early, you have the opportunity of avoiding a surgical treatment for something that might have been avoided. So Anthem feels quite confident that we properly submitted claims, coded properly, we are going to reimburse for this. Therefore, that's my neutrality on the bill. We don't like sort of an unnecessary kind of mandate, or one that maybe could be more clearly drawn around instead of just public therapy around a disorder. So a caution on this. The other thing I wanted to point out is the issue around somehow the passage of a bill on this topic would somehow result in a federal pushback at the state level and ask for costs to be covered by the state of New Hampshire is something the insurance department has to wrestle with. My understanding is that I'm not so sure that feature of the Affordable Care Act has actually ever been utilized. So I wouldn't worry about that too much. What I would worry about more is the fact that you're putting something on the books which may be quite unnecessary. And so that's my neutral presentation. Surely, if I leave here, and I often this happens, and somebody comes up and says to me, well, I did submit some claims to Anthem and there were problems. I will certainly let you know that, but I also would want to work with that person and sign them up with somebody that works with Provider Solutions to straighten out what may have been the mismatch. Because a claim properly submitted for a pelvic floor disorder, basically establishing the necessity, medical reasons, therapeutic reasons should be responded to in a favorable fashion by Anthem.
Thank you, Madam Chair. Thank you for your, I was waiting for your testimony because it was mentioned that a possible mandate study could be suggested, which would be helpful to.
Now, the mandate study, and I think the department person's still here, and she could respond to that better. But there used to be a contracted provider out there that would be handed, usually came out of Commerce Committee in the House, handed the testimony and, the various protocols around who was saying what to whom, and saying, would you please price this? How would it add to premium in the insurance market? And oftentimes there would be some addition to premium, so the discussion would then come, well, do we really want to leave that mandate off the individual market, which is a more troubled market, and leave it only on the small and large group? Well, the small group market's pretty troubled these days also. So it's informational, and it would take a while. You wouldn't have it next week, let's put it that way. You might get it later in the spring if you had a contract provider ready to provide the service.
Thank you.
Thank you, Madam Chair. Thank you for taking my question, and I appreciate your reference to, what the insurance company, insurance department often comes in and raises this specter about the state having to pay back deferred costs. But I appreciate your information that the government has never done this, and in particular, never done this in New Hampshire. Which is significant considering how long the ACA has been in effect. So I wanted to, is Anthem provides coverage in Maine, correct?
Yes, and I have the Maine law here if you'd like to see that.
And so that's what I wanted to sort of clarify. My understanding is that this coverage of pelvic floor disorders, an associated thing, that hasn't raised in premiums in Maine, correct?
To my knowledge, no. But the interesting part of that is Maine has, this was a special, it's an act to clarify health insurance coverage for postpartum care. And I just like the terminology. If you were to go that way, and I'm not suggesting you should, frankly, you would want to use some sort of language that is more than simply therapy, because you want to preserve that issue of medical necessity. So that's my response to that.
Yeah, follow up. Thank you, actually, Paula, for saying that, because that's the other thing that I was going to sort of ask you, which language you preferred, knowing that Anthem is both in Maine and New Hampshire. In the Maine mandate, you're correct that it does say pelvic floor disorder. And so I'm wondering if that's something that this committee wants to consider to be consistent. Instead of saying specific coverage for pelvic floor therapy, we might want to say coverage for pelvic floor disorders. So I appreciate that.
And I might add to that if I have just a moment. The thing in Maine that is different is they really sort of get into postpartum coverage. And so I know we're dealing with that maybe at the Medicaid space at the moment. So there is no replication of that concept in existing insurance law. So this would sort of stand as one of those freestanding sort of mandates. And to your further, perhaps, interest, there are tens of mandates in New Hampshire, all the way from, enteral formulas to hair prostheses, whatever you want. And they're important. This is, to me, more a lapse in consumers' understanding, and in the OBGYN area, and probably in the gastro area, and in the pure physical therapy area, with a primary care provider who says, yes, I think you have this issue. You need to be evaluated, and then you need your physical therapy. So that's and you know where this really gets me going, and I'm sorry, I'll just one more thing. I have been listening to alternative treatments for opioid service care, and it's the same issue. The primary care provider or the other provider doesn't sort of understand the array of opportunities to avoid opioid and go to a presently covered service. And instead of saying, okay, PT, OT, maybe some osteopathic, whatever, they go immediately to Tai Chi. When, wait a minute, there's a group of providers that can do clinically appropriate things that are already certified. Do we need to go to certify a Tai Chi instructor? They're wonderful people, I'm sure, but So what I'm saying is, I think we're missing the point, and the provider community needs to be a little more engaged.
Last follow-up? Thank you for mentioning that. I mean, and I understand sort of this tension between education certainly is required, and also, women are experiencing these really preventable things like peeing their pants on a daily basis. So my perspective is education, yes, but also let's make it clear in the statute. And so that's, I guess that's not a question, it's a comment.
Well, there was a mention, of course, of the fact that providers aren't aware of this, and therefore there are fewer providers. Providers are very aware. Providers are aware that as much as there's this tension between providers and insurance companies, they need each other. And so providers, I think, sort of are pretty good advocates. And so I don't know what to say. That's my reaction. It's not fixable like that, but I'm not sure it's so much of a problem.
Any other questions?
No.
Thank
Seeing
you.
none?
I will close the hearing on 176, and we will recess until 1 p.m. It'll be fun. Well, it takes a long time to go. Well, so.
What's the next bill scheduled?
Oh.
Yeah.
Madam Chair, and good afternoon, members of the Senate Health Committee. And I have for your consideration today Senate Bill 172 FN, which seeks to allow court-appointed guardians to receive temporary assistance to needy family benefits. Let's see. The purpose, the purpose of this bill is to recognize the importance of what is known as fictive kin in caring for New Hampshire's children. Sometimes when a parent is unable to continue caring for their child, friends, neighbors, or other adults will step in, and TANF benefits are limited to children who are being cared for by an adult relative. This bill extends TANF benefits to non-relatives caring for children deprived of parental support, so long as they are court-appointed guardian of the child. I have Associate Commissioner Christine Santiello here with me today, and she should be able to answer questions for you. So thank you very much for your time this afternoon, Madam Chair.
Thank you, Senator. Any questions from the committee?
No, you did a great job.
Thank you, Senator.
Thank you, Madam Chair.
Assistant Commissioner? Welcome.
Well, thank you. This chair goes like this. So. Okay. I can figure it out. What? They all do?
I've been complaining about that chair.
Wow, I feel like I'm really in the hot seat today. So no, just kidding. And this is a good thing. So thank you for hearing me today, and thank you to Senator Carson and all of those that signed on to Senate Bill 172. Like the senator said, my name is Chris Santinello. I'm an associate commissioner at the Department of Health and Human Services. What this bill allows is for fictive kin, so those kin who do not have a biological relationship with the child receive temporary assistance to needy families. And this actually came about due to two people here that will be speaking later today. Last spring and summer, DCYF Commissioner Joe Ribson and I went and visited some family resource centers. And it was at that time that we talked with Shannon, who is back here, who talked to us about a family, the Millers, who are also here. And they took in a young child who did not have a blood relationship with them. They were court appointed. They weren't through DCYF, so they weren't able to get foster care payments. And because they did not have a blood relationship, the department was unable to find them eligible to receive TANF. And so ideally, when children cannot be raised by their biological parents, they should be raised by kin, whether that is blood relation or due to a strong relationship, so they can remain in their community. To assist, we really need to think about all families, including those that are called fictive families. This is one step in that direction. This helps keep families and children connected to their community, and many kinship families are not involved with our Division for Children, Youth, and Families, so they cannot receive a foster care stipend. And we want to keep it this way. We don't want to have children come into the system just for some financial assistance. And so in an effort to keep children out of our child protective system, providing some form of financial assistance can really help to stabilize these children and families. So really, in closing, I think all I want to say is this bill gives us the opportunity to change the system for the child and not change the child due to our system. Thank you.
Any questions from the committee? Seeing none, thank you, Commissioner.
Thank you.
David Miller?
Good afternoon. My name is David Miller. And I appreciate you giving me the opportunity to come down here and speak to this today. We actually took in 3 children, their siblings, that are now 17, 13, and 8. We have 2 adult children of our own. And due to their parents being in and out of incarceration. One just got out of jail, another is still in jail. So we gave these children a place to live. This was 4 years ago, January, we took them in, supposed to be on a temporary basis. And they're all three of them are really good athletes. So we put them in basketball, baseball, soccer camps, all sorts of stuff. And obviously with the rising price of food and fuel and everything else, transportation, my wife and I put out a great deal of money supporting these children. And this bill will help hopefully alleviate some of that. And if it doesn't help us, it'll certainly hopefully help somebody in the future. Appreciate your time.
Thank you. Any questions from the committee? Seeing none? Thank you, David. Tina?
Hello, I'm Tina Miller, and like my husband said, 4 years ago, we took in 3 children we didn't even know, and they asked us to take them for a couple days, and a couple days has turned into 4 years, and, you know, we didn't have to do this. We were empty nesters. We were gonna travel and do whatever we could do. My husband was gonna retire, but, you know, now we don't. We can't, because we have to work full-time, and he works a couple jobs, and their family had them, but they had them for the wrong reasons. They had them because they could collect, because they were blood relatives. And so we took the children and we received nothing for them. No, nothing. Absolutely. I mean, the oldest son, our Dre, our child we have guardianship of, he goes through probably 2 or 3 pairs of basketball sneakers a season. He's an avid basketball player. His sneakers, yeah, they're $300 a pop. You know, basketball camp was $1,500, and that's just one of them. And now the little guy, he's coming up, he's 8, and he's into all the same sports as his brother and sister. You know, and my birthday was Sunday, and the 13-year-old, she is attached to me at the hip because she's like, I don't know what I'd do without you. She says, it scares me to think where we would be. And it's like, what do you do? You know, she goes, you didn't have to take us in. I'm like, no, we didn't have to. She says, but if it wasn't for you, where would we be? And so obviously we didn't do it for any money, you know. And if it doesn't help us, it will definitely help somebody else. We cannot be the only people out there saying, you know, gosh, when the pandemic and we were able to get the pandemic food stamps for them, that helped out so much. Our grocery bill alone is just under $350 a week probably with them. They're active. They eat a lot. And yeah, yesterday I ran back and forth to the school 6 times to get kids, dropping them off at practice, coming back, because they're all staggered. You know, that's gas, wear and tear on the car. A little bit would help somebody. So I thank you guys for listening to everybody for this and letting us speak on behalf. Thank you.
Thank you, Tina. Jolyn?
Page, there's the Miller's story in our good afternoon. My name is Jolyn Drennan. I'm the Senior Program Director at New Hampshire Children's Trust. I'm here today in support of State Bill 172 and to share the insights gathered over 3.5 years since the inception and launch of New Hampshire's statewide Kinship Navigation Program. Rooted within New Hampshire Family Resource Centers, the Kinship Navigation Program provides an array of supports to kinship families, regardless of child welfare involvement, relationship, or legal status. The program is free, voluntary, and aims to strengthen and sustain the well-being of kinship caregivers and their families by reducing systems barriers and economic stressors, and by increasing family protective factors, so to decrease placement disruptions for children in kinship care. So here's what we've learned in the last 3.5 years. So we know that a child's need for uninterrupted sense of love and belonging is necessary for healthy development, and a growing body of research indicates placement with kin is the next best option when a child cannot safely remain in the care of his or her biological parents. We know that many children have bonds with individuals who are not related by birth, adoption, or marriage that are just as strong as others have with blood relatives. These fictive kin can, and do, provide care and stability for a child when out-of-home placement is necessary. And we know that despite the prevalence of kinship care arrangements both in and outside of the foster care system, there are many contexts in which the law does not recognize fictive kinship relationships. We know there are very few supports available to fictive kin caregivers beyond those provided in the Kinship Navigation Program. We know that relative or fictive kin placement reduces the trauma of family separation, enhances child well-being and behavioral health outcomes, and increases the likelihood of achieving permanency. Therefore, placing these children with the people who can best care for them requires laws that treat fictive kin the same as relatives. Across the nation, lawmakers have recognized that allowing fictive kin to be considered relatives improves state welfare outcomes. In the context of subsidized guardianship, expanding the definition of relative to include fictive kin maximizes the amount of federal funding provided for subsidized guardianship by expanding the pool of potential eligible guardians. Supporting fictive kin can also alleviate the recruitment and retention issues facing foster care agencies. However, relative and fictive kin caregivers differ from foster parents because they are unlicensed when they first accept children into their home, which means they are not entitled to financial support that non-kin foster parents receive. And for families like the Millers who exist outside of the system get nothing. As a result, kin families experience severe financial strain, and many are retired or living on fixed income. Some are living at the poverty line already, and some may be in poor health. The effort to expand TANF eligibility to court-appointed guardians, including fictive kin, demonstrates New Hampshire's commitment to the health and well-being of our most vulnerable families and children. There's still much work to be done, but this is a huge step forward for New Hampshire, and I'm grateful to the senators sponsoring this bill for recognizing this and taking action. On the side note, we have a considerable amount of data related to out of the Kinship Navigation Program, and so if there is a time that you would like to hear any of that data, or if there's anything that could support this bill further, I'm happy to provide that. And then just in our current data that I just kind of pulled some before I left the office today. Just to give you an overview of the needs of families, and this is all kinship families, they are all so 738 families that we're serving. They all have significant financial needs. We are providing an average of $522 per family. Out of some federal funds that we have, and then also some private funds that were provided by the New Hampshire Charitable Foundation. And the needs range from everything from medical expenses that are not covered by Medicaid, to cough medicine, to respite care, to a vacuum cleaner. We had one single grandparent that needed a vacuum cleaner just so that she could vacuum the floor and keep it clean, so that the baby was learning to crawl around. So things like that. These really large expenses to really minute expenses, and no one's getting rich off of TANF money. And I have a lot of data to support the scope of income levels and needs, and who and where and demographics. So, thank you.
Thank you, Jolynn. Any questions from the committee? Seeing none, thank you. I have Shannon Lavertu supporting, but you don't say whether you want to speak or not. Did you want to speak?
Sure, I'll say a few words.
Okay.
Thank you. Thanking you for allowing me to speak. So I'm a kinship navigator with the Family Resource Center based up in Berlin-Gorham area.
I'm not only a kinship navigator, but I'm also a kinship caregiver. And it was easy for me to prove my lineage. Took 5 birth certificates, but I was able to receive relative care through the state of New Hampshire. Going back to that, when we first got my great nephews, I went up and applied because I was told that you could get relative care money. So I did, and at the time my husband had just been disabled, so we were receiving SNAP benefits for a family of 5, and I believe it was like $400 a month. So when I applied for the relative care for the 2 boys, they gave me the stipend. I think it was $300 and something twice a month. But the minute I did that, they took away the food stamps. Even though my family moved up to 7 people, they counted their income. So we lost the SNAP benefits. We got some cash, but we lost the SNAP benefits. Fictive families don't even get that. Once they take in, when I help my clients apply for benefits, whether it's fictive or kinship, the first thing I say is, if you're applying for Medicaid for the children, we're just going to apply for Medicaid for the children. If you apply for SNAP, we have to take in all the income, and the process is daunting. It really is a lot of paperwork. You have to submit everything from soup to nuts, pay stubs, mortgage payments, car registrations. It's just very, very daunting, and I already know that they're going to get denied because there's no relative connection there. So this bill will go to support those people, like the Millers, who take in children just out of the kindness of their heart, who want to see those children succeed. And we've always said, strong families make strong communities. Who knows? This might be the next Shaquille O'Neal. I don't know, but I've seen them in action, and they are great children, and they're funny, and the Millers have done a wonderful job. So thank you for considering this bill. We really appreciate it.
Any questions from the committee? Seeing none, thank you. Is there anyone here, that was the last speaker, is there anyone here that would like to speak on this bill but hasn't been given the opportunity? Sure.
I don't like talking. My name is Rosemary Nugent, and like Shannon, I'm a kinship navigator at the Grapevine in Antrim, New Hampshire. My families that I'm working with are all relative caregivers, but I do have somebody that I know raising friends of their children, receive nothing. This woman has gone to the ends of the earth to see something like this happen. She's formed Facebook groups. She is instrumental in having families get together for different events. And I'm hoping for her sake and the Millers and all the others that this bill gets passed. So thank you.
Thank you. Commissioner, can we have you come back up for a minute? I actually have a question too. Senator Bradley.
Thank you very much. So in looking at the fiscal note, this is total federal funding.
100% federal funds.
So my question is, should we move up the effective date to passage or July 1st?
So the issue we have is we have to make some system changes within our New Heights eligibility system. So we would not be ready to be online.
Thank you.
I do have one question.
Okay.
Looking into the Miller's case now, they're not getting any money, but previously the family that the children's parent or family kin were receiving money. Are they still receiving money?
If the children are not with them, they would not be receiving those dollars.
Okay, great. Thank you.
You're welcome.
Is there anyone here that would like to speak again on this and has not been given the opportunity? With that, I will close the hearing on Senate Bill 172.
Yes.
That's them.
It is. Good pickup, I didn't know.
Go to the chair.
Well, you've sat here before.
All right, I will open the hearing on Senate Bill 173 relative to surprise medical bills, and the prime sponsor, welcome Senator Carson.
Thank you again, Madam Chair. It's an honor to be here this afternoon with you and your committee members. For the record, my name is Sharon Carson. I have the pleasure of representing Senate District 14, comprising the towns of Londonderry, Hudson, and Auburn. And I have for your consideration this afternoon Senate Bill 173, relative to surprise medical bills. This bill requires insurers to cover emergency services provided by non-participating providers in the same manner as if the services were provided by a participating provider, and requires the insurer to pay the non-participating provider the out-of-network rate less any cost sharing for the services provided. This bill prohibits surprise medical bills and balance billing. This bill is also the request of the insurance department. The insurance department seeks to amend multiple laws in response to the federal No Surprises Act. The purpose is to clarify primary regulatory authority for enforcing certain No Surprise Act protections. It establishes New Hampshire Insurance Commissioner's exclusive authority to resolve surprise billing disputes between a provider or facility and health carriers. It expands surprise billing protections in New Hampshire law to align with No Surprise Act's standards. It revises existing balance billing protections in New Hampshire law to again align with the No Surprises Act standards. It establishes rule writing authority related to price transparency for healthcare services, and it expands the patient bill of rights to require notice of a surprise billing protection. Deputy Commissioner DJ Betancourt is here from the Insurance Department to give a more complete understanding of these changes and to answer any questions the committee may have. Thank you very much for your consideration of this legislation.
Thank you, Senator Carson. Any questions from the committee? Seeing none, thank you. Can I have the department come up? Welcome.
Thank you, Madam Chairwoman. Members of the committee, good afternoon. My name is DJ Betancourt, and I have the pleasure of serving as the Deputy Commissioner of the New Hampshire Insurance Department. I am joined today by my colleague, Alex Feldavel, and we are here in support of Senate Bill 173. As Senator Carson just mentioned, we did request this bill, and it is, in our view, the most important piece of legislation that the department is pushing this year. New Hampshire's history of addressing surprise medical bills and being at the forefront of protecting consumers against them is something that every member of this legislature can be proud of. In 2018, Governor Sununu, the legislature, and the Insurance Department worked together to pass legislation prohibiting out-of-network anesthesiologists, pathologists, radiologists, and emergency physicians from surprise billing a commercially insured patient when that care was provided at an in-network facility. It is important to note that the state law only provided protections to fully insured plans that are subject to state law and oversight by the Insurance Department. Building on those protections came the federal No Surprises Act, which, as I said, extended those protections and ended the practice of surprise billing in most other aspects of commercial insurance. But importantly, it provided protections to self-insured or ERISA plan customers. It should be noted that the No Surprises Act was sponsored by Senator Hassan, passed with large bipartisan support in Congress, and was signed by President Trump into law. So whether it's here in New Hampshire or in Washington, there has been a long history of enormous bipartisan support for ending this practice. Following the passage of the No Surprises Act, the question became who would be responsible for its enforcement. To the federal government's credit, they acknowledged and respected the long-standing principle that the regulation of insurance is a state function. This is a principle that states have fought for and protected since 1945. As such, the federal government provided the states with the opportunity to take all enforcement aspects of the No Surprises Act that state wanted to assume. And in those events that the state did not want to assume those functions, they would defer back to the federal government for enforcement. We are here today because the New Hampshire Insurance Department is prepared, willing, and capable of taking on the role of enforcing the No Surprises Act, and we can do it more effectively, faster, and cheaper than the federal government, and with no additional staff. We have a history of doing this work effectively that we can cite. I asked our consumer division to run some numbers for me. As balance billing protections came online, the number of complaints coming into the department plummeted in some areas and went up in other areas. Now, some of that makes sense. As people become more aware of the protections that they have, they're more likely to seek out those protections. So that's not surprising. However, we had 0 requests for the department to arbitrate a dispute between a carrier and a provider for the balance billing protections that were in state law. In terms of the dispute issue, which I believe is going to be the predominant point of discussion here today, you're going to hear some concerns about that. And I do want to again point to the fact that we have had 0 requests for the department to arbitrate in the areas that we can, and we think that there are predominantly 2 reasons for this. First, with the exception of one hospital system, all other hospitals are in-network in New Hampshire, and so therefore balance billing issues do not arise in those facilities. Second, the industries don't want the department to be the arbiter of these disputes because it sets precedents, and those precedents begin to resemble a fee schedule, which the insurance industry does not want. So there is a strong incentive for the insurer to negotiate in good faith with the provider to find a commercially reasonable rate. We brought this legislation forward last year, and the legislature passed on it. Some opponents raised concerns about the dispute resolution process and the fact that there was federal litigation challenging certain provisions of the No Surprises Act that were ongoing. To be honest, we were a little disappointed. But over the course of the last year, we have seen the reasons why we believe we need to move forward, play out, and be strengthened. So in that sense, the delay was a bit of a gift in disguise. In the first instance, the federal government changed some of the rules around the No Surprises Act that addressed the issues raised in the initial litigation. Second, we are seeing that the federal dispute resolution process is breaking down. They are having difficulty finding a sufficient number of independent dispute arbiters, and as a result, there is a big backlog of cases. As a result of that, the costs to the parties is increasing. The fee the parties must pay to arbitrate has skyrocketed 600%. The process takes a long time, and worst of all, when the process does get arbitrated and a payment amount is reached, there are significant delays in getting the payment out the door to the provider. I stress this because until the issue is resolved and the payment is issued, that bill continues to hang over the head of the consumer. We have seen this play out for consumers in New Hampshire over at the department, and we know of one instance where a carrier in New Hampshire has had 4 claims arbitrated and none of those bills have been paid. And not surprisingly, this is most likely to happen when the insurance carrier loses the dispute. Our department would never allow that to happen because unlike the federal government, we have the regulatory authority to enforce the payments. The federal government does not. When providers and consumers approach us and we advise them that they must use the federal process because their particular issue falls outside of our jurisdiction, we hear back from them that they feel that we have sent them into a black hole. And for an agency such as ours that prides itself on consumer protection and consumer service, this is a painful bit of feedback to get from our residents. I'm going to hand it over to my colleague Alex, but we believe the fundamental question is whether you think New Hampshire or Washington can do a better job of enforcing this important law. In New Hampshire, a consumer can pick up the phone and reach a member of our team within seconds. The same cannot be said for Washington. The average wait time to resolve a consumer complaint in our department is between 1 and 30 days, depending on the issue. The same cannot be said for Washington. The state has been enforcing balanced billing protections for 5 years. The same cannot be said for Washington. We believe that the enforcement of the No Surprises Act should rest with the New Hampshire Insurance Department, and I'll turn it over to Alex.
Thank you, DJ. I'd just like to emphasize that, that because of the provision in the No Surprises Act, it's known as reverse preemption. It basically says if a state has a law governing this subject, that is the law that will govern. We have a double standard going on in New Hampshire because New Hampshire's already passed a law that deals with the situation where you go to an in-network facility, but then you receive services from an out-of-network anesthesiologist, pathologist, radiologist, and a process for that. So the federal agencies responsible for enforcing the No Surprises Act have us categorized as a bifurcated state. In certain situations, the disputing parties are shunted to the state of New Hampshire. In other situations, their only recourse is to the federal independent resolution process. So what we're trying to do with this bill is expand our footprint from what it is to match the federal footprint. So the federal balanced billing law not only governs that in-facility but out-of-network provider, but emergency services and the air ambulance. So that this bill expands it and at the same time adopts the federal standard for what a reasonable payment amount is, a commercially reasonable amount. So would be applying the same standard the federal government has in the No Surprises Act, but we'd be doing it at the local level, we believe, much more efficiently. And that's the main point I wanted to add.
Thank you. Any questions from the committee? Oh, Senator.
Thank you. Thank you, Senator Birdsdale, and gentlemen, thank you for being here this afternoon. Did I get it right, Senator Birdsdale? No, it's a long day. Okay. So last year, when you came before this committee, and I wasn't on the committee then, I raised an issue, and I actually raised it with you by email about your authority or about the inclusion of air ambulances in particular here. Because as I understand this, air ambulances, including billing, are regulated or solely regulated by, well, the Airline Deregulation Act says that, you know, it is up to, if it's the FAA, to manage this, including billing. And there's been, I know one circuit court decision, which was not in our, you know, within our network, but there may have been two that uphold this. So I see it in here again that, and now it's inserted in actually the EMS statute 153A. So I'm just trying to understand how, you know, so is today Groundhog Day? No. It's tomorrow? Okay. So respectfully, I'm like, we're back. What's up with this?
Absolutely. Well, first and foremost, Alex owes me a Coke because I bet him that you were going to raise this. So Alex, that'll be a Diet Coke, please. Alex and I chatted about this very issue before we left. We looked into it. I took a look at what I had provided you in terms of information last year, and we believe that that information holds up, which is that it was a proper delegation of the federal government to the state around air ambulance. Alex, anything you want to add? Yeah. They do have that ability because what you're dealing with is the billing of the event. You're not talking about a delegation of the airline industry or the flight patterns or any of those other things that are appropriately left to the experts at the FAA. We're just talking about the billing transaction as it pertains to the medical service.
Thank you.
Mhm.
No, no fault. Any other questions?
All right. Thank you
Thank
very
Senator.
much.
Thank you, members. I'll send you guys an email copy. Sorry.
Welcome.
Yes, I'll send you an email copy. Thank you.
Welcome.
No worries. Thank you very much for having me. My name's Eric Liu. I'm a pathologist that works up at Dartmouth, but I'm here as president of the New Hampshire Medical Society and also as a representative from the Society of Pathologists to talk about this. In general, like many that might be in the room also, I was here last year presenting opposition testimony against this, and SB 173 is very similar in intent to SB 287. The Pathology Society and the Medical Society are both opposed to this for two main reasons. The first one is that we feel that the current law is working well and doesn't really need to be changed. The second is that the proposed language in SB 173 gives our insurance commissioner a unusually broad and exclusive regulatory authority over reimbursement for our services. In reference to the first point, the existing New Hampshire law protects patients from out-of-network balance bills and conforms to the No Surprises Act. On December 22nd, 2021, correspondence to the New Hampshire Insurance Department and Governor Sununu from the federal government, HHS and CMS, definitively recognized that our current New Hampshire law as a specified state law and determines that it meets all of the federal requirements. And I'll quote as follows, and I did provide a copy of that, and I'll email it to you afterwards. Based on the survey response and CMS communications with the New Hampshire Department of Insurance staff, CMS understands that New Hampshire RSA Title 30, 32931-B3 is a specified state law that will apply for purposes of determining the out-of-network rate with respect to anesthesiology, radiology, emergency medicine, or pathology services furnished to individuals in a managed care plan in New Hampshire by a health care provider in a hospital or ambulatory surgical center that is in network. And in addition, to date, and as confirmed by the representative from the New Hampshire Insurance Department, there really haven't been any concerns or problems that have manifested as a result of the current law that we have in state that would really necessitate the changes that are being proposed in SB 173. Now, in addition to that first concern, the second concern that we have is that the proposed language in SB 173 would negate the negotiated agreement that we had come to in 2018, and instead would confer the commissioner basically unilateral, unfettered discretion to determine the out-of-network rate based on his determination of what is in the public interest. And I feel that the subjective interpretation of what may or may not be in the public interest is a very nebulous standard for fair reimbursement of healthcare services. And to my knowledge, there isn't a single state in our union that uses that standard for reimbursement of these services. So we urge the legislature to retain the current standard that were negotiated in 2018 that directed the commissioner to determine out-of-network rates and payments for such cases that may need adjudication using our current standard that requires amounts to be commercially reasonable. Therefore, we urge the legislature to oppose SB 173 and retain our current laws. Thank you very much.
Thank you. Any questions from the committee of Dr. Luke? All right, seeing none, thank you. Paula Minahan?
Good afternoon, Madam Chair, members of the committee. For the record, Paula Minahan, Senior Vice President, State Government Relations with the New Hampshire Hospital Association, representing all our hospitals. We do have significant concerns with Senate Bill 173, and it does appear that this is very similar in intent to Senate Bill 287 from last year. That bill was amended here in the Senate and then was voted, I believe, interim study in the House Commerce. It did not get through last year. We continue to have the same concerns with this bill that we raised last year. And as soon as the bill was posted on Gen Court, we did some outreach to the department, working with some of our stakeholders to ask to meet with them. We just haven't had a chance to meet since this hearing was held. But our initial review of the bill has raised significant concerns for us. Specifically, Senate Bill 173, as did 287, grants exclusive regulatory authority to resolve disputes between a carrier and a provider to the Commissioner of Insurance. The healthcare providers, including hospitals, are not regulated by the Department of Insurance, as you're well aware. They're regulated by HHS. We do not believe this approach is in the best interest of all affected parties. While Senate Bill 173 attempts to codify in state law the Federal No Surprises Act, this bill goes well beyond the goal of the No Surprises Act and adds provisions in the insurance statute and other statutes that relate to healthcare facilities and healthcare provider licensing. Again, our concern is the expansive authority given to the Commissioner of Insurance, including areas where the Department of Insurance would have oversight authority. There is no less than 3 sections of this bill that refer to granting exclusive authority to the Commissioner. Page 2, lines 15 through 17, page 3, lines 32 through 36, page 7, lines 11 and 12, page 4, lines 22 and 23 refer to granting authority to the Commissioner to set reimbursement rates. That's equally concerning to us. Additionally, the Patient Bill of Rights, which is RSA 151, that falls under health facility licensing, is amended on page 6, lines 20 through 26. This is also an area of concern to us. Inserting language about out-of-network insurance coverage in the Patient Bill of Rights is, in our opinion, not appropriate. The Patient Bill of Rights is about patients' rights while receiving care in a healthcare facility. We're opposed to adding this information in that statute. We believe it would add unnecessary confusion to patients seeking care at hospitals. While it's important to mention that the patient and the consumer is already protected by the federal regulation, under current law, balance billing for out-of-network providers is not allowable under federal law, outlined in the Federal No Surprises Act. Again, further, the provider and payer, if there is a dispute, can follow the federal dispute resolution process. And I think it's important to mention, I don't believe any of our to my knowledge, no hospitals in New Hampshire have gone through the federal dispute resolution process, but I know that there are they have reported there are delays in that process in getting the dispute resolution contractors up and running. But I would argue that this harms the provider, not the carrier. And again, I think it's important, and I reiterate this over and over again, the patient is not held in, there's no problem with the patient being held liable or being in the middle of all of this. They are not. That is the requirement of the No Surprises Act. The dispute and the debate, if you will, is the dispute resolution is between the payer and the provider, not the patient. While we are happy to further have discussions with the department regarding this bill, we do question the need for this bill and remain concerned with the bill as drafted, and thank you for the opportunity to speak. Happy to answer any questions.
Any questions of the committee? Seeing none, thank you. Chris Staywas?
He's out of uniform.
Welcome.
Don't recognize you when you're not in uniform.
Thank you. Good afternoon, everybody. Thank you for the opportunity to testify today about Senate Bill 173. My name is Chris Staywas. I'm a lifelong New Hampshire resident residing in the town of Hollis with my wife and family. I've been a nationally registered paramedic for the last 39 years and spent my entire career in the New Hampshire emergency medical services industry. I'm currently employed by American Medical Response, which is New Hampshire's largest 911 provider. I have a couple of concerns with the language as currently written that I would like to point out and comment on, specifically in line 34B. I think it's on page 2 or page 3. They're not page numbered. Yeah, page 2, I'm sorry. 34B, non-participating provider means any healthcare provider who is acting within the scope of practice of that provider's license or certification under applicable state law and who does not have a contractual relationship directly or indirectly with a healthcare or group health plan as defined in section 42 et al. I would suggest
Chris,
inserting...
Can you just repeat that?
Yeah, that's on page 2. What did I say the line was? 34B. Siri's looking for it too. I would suggest inserting excluding ground ambulance language, as I believe the intent is to have this apply to medical facilities, physicians, and air ambulances. Interestingly, I believe air ambulances are a moot point as the Federal No Surprises Act already prevents balanced billing for that industry. And more importantly, as was discussed earlier, the Airline Deregulation Act remains totally intact. Thus, states have no jurisdiction over rates and routes, including insurance and membership of air ambulances. So I'm concerned that the unintended consequences toward ground ambulances by this language change. It's my opinion that New Hampshire is repeating a version of the federal NSA, which is not a criticism. However, the NSA expressly excludes ground ambulance services until a solution is found to include them. The federal NSA initially excluded both air and ground ambulance from its reach, and as you may know, our own Senator Prentice currently sits on the Federal Ground Ambulance and Patient Billing Advisory Board representing state insurance regulators. I recommend that ground ambulance be expressly excluded from this legislation until that federal committee has finished their work and come forward with recommendations for the entire nation, as they did with air ambulance. Again, reminding the committee that air ambulances are already under the federal NSA, thus the New Hampshire citizens are currently protected from air ambulance surprise medical bills. Thank you for the opportunity to speak. Happy to answer any questions.
Thank you, Chris. Any questions from the committee? Seeing none?
Thanks.
Thank you. All right, that is the last speaker. Is there anyone here that would like to speak that wasn't given an opportunity? With that, I will close the hearing on Senate Bill 173 and give Cam a little bit of time to get organized.
Good afternoon. Hey, right. Yep, I know. Wait, the have a seat over there. So.
All right. We will start the hearing on Senate Bill 174, and welcome again, Senator Carson.
Madam Chair, it's a pleasure to be in front of your committee this afternoon.
Honorable member of our committee this afternoon.
For the record, my name is Sharon Carson. I have the pleasure of representing Senate District 14, comprising the towns of Londonderry, Hudson, and Auburn. And I have for your consideration this afternoon Senate Bill 174, relative to veterans' access to health care. This bill repeals two unfunded statutes to health care and mental health services for veterans. This bill also instructs the Department of Health and Human Services and the Department of Military Affairs and Veterans Services to report to the Oversight Committee on Health and Human Services regarding veterans' access to health care and mental health services. This bill is a request of the Department of Health and Human Services and the Department of Military Affairs and Veterans Services. Madam Chair, these departments continue to work collaboratively to leverage all available resources to meet the needs of New Hampshire service members, veterans, and their families. The close collaboration between DHHS and DMAVs, along with the support of the U.S. Department of Veterans Affairs, New Hampshire hospitals, and community mental health centers, renders the need for navigators as intended by these statutes unnecessary. RSA 126A:81 and 82 do not improve the current practices that are already optimizing access to all services for veterans' health. That includes health, behavioral health, education, financial, employment, etc. Implementing these provisions will disrupt the effective practices currently in use. 126A:81 requires DHHS to train and use veteran service officers employed by DMAVs to train veteran health navigators to identify all federal and other health benefits, coverage, and services available to veterans and their families. This will adversely impact the service officer's ability to perform the core mission of connecting veterans to VA and state benefits. The requirements of 126A:82 are currently being met without the need for additional resources. The Division of Community-Based Military Programs, in coordination with DHHS, is facilitating partnerships with state, federal, and community providers to deliver services to New Hampshire's veterans, service members, and their families. This includes improving service delivery, ensuring cost efficiency through decreased overlap, and improving access, navigation, and coordination of services and support. The provisions of these two statutes have not been implemented as there has not been sufficient funding to carry out their purpose. There is a caveat in the RSA which says funding these provisions to force implementation would prove to be redundant and wasteful. Funding these requirements would be throwing funds at a problem that was solved by the creation of the Department of Military Affairs and Veterans Services in 2019. I thank you very much for your time this afternoon, Madam Chair. And Warren Perry and Wendy Altman are here to answer your questions. So thank you very much.
Thank you, Senator Carson. Any questions from the committee? Seeing none?
Thank you.
I'm sure Judiciary will be glad to have you back.
Maybe not.
Thank you very much. Thank you, Senator.
Warren Perry? Welcome.
If it pleases the chair, we could testify jointly.
Absolutely.
Thank you. Bring the chair up. Madam Chair, members of the committee, for the record, I'm Warren Perry. I'm the Deputy Adjutant General for New Hampshire's Department of Military Affairs and Veteran Services. And with me is...
Hi, good afternoon. My name is Wendy Altman, and I am the Bureau Chief at the Bureau of Elderly and Adult Services at the Department of Health and Human Services.
So first, we'd like to say, express our gratitude to Senator Carson, Senator D'Alessandro, Representatives Massimilla, Edwards, and Moffett for agreeing to sponsor this bill. It's a very important bill to us in terms of continuing what we have begun in the Department of Military Affairs and Veteran Services when we rolled all of the veterans portfolio underneath the Adjutant General in 2019. It's been a success, and we want to continue along that road. We continue to have a robust relationship with the Department of Health and Human Services, with Wendy, and also Karen Hebert, who sits on the military leadership team. So this really continues the path that we're already on without creating another fiscal or financial or resource burden on the state. I don't want to repeat what Senator Carson said, but I do have specifics about some of the things that we are doing across the community with our federal, state, local partners, our nonprofit partners, and our providers across the state. In the last biennium, in HB2, there was a $1.5 million appropriation and we have continued to request that in the governor's phase of this year's operating budget. We expect it to be funded to help continue to provide access and improve access, reduce social isolation, and improve mental health services to the veterans across the state. So currently we have two contracts, one for $400,000 with Easter Seals and one for $350,000 with the Partnership for Public Health to do just that. And I can get to this, I can answer specifics about those if you want to do that, but specifically working at improving access to services and reducing social isolation and improving access to mental health services. We've also created some toolkits for providers across the state, and including a complimentary video series that are posted on our YouTube channel for the department and our Facebook pages that help providers not only identify veterans who present, to help them get access to services that may be available to them based on their veteran services, but also when they identify them to know exactly how to provide culturally competent care for veterans. Like we make the analysis. You don't need to have been sexually assaulted to understand how to treat victims of sexual violence, but you do have to understand them. So we do this for veterans as well. You don't necessarily have to have been a veteran to provide care for veterans, but you do have to be able to provide culturally competent care and know those sensitive questions to ask or not to ask. We also have created a marketing contract to promote the department's initiatives and programs to increase awareness to our services across the state. So without these navigators, we can teach veterans and their family members how to find the services without having to have navigators. So that's kind of what we're doing now, and we're going to continue those in the future. And it kind of eliminates the need for these navigators. The concept is good, but in implementation, if we implement it in the way the statute outlines is, we're going to take away from the capacity of the veteran service officers to do this, right? So we have, by way of context, we have veteran service officers. Their job is to connect veterans to their benefits based on their service, right? So you've earned benefits based on your service. We're going to connect you to them. What this law does is tries to make them insurance experts and try to make them case managers. And we really don't want them doing that. We want them to take a veteran, get them connected to their benefits and move on. So, we don't want to detract from that important mission that they have. We only have 7 of them, and we don't, they're touching about 300 veterans a month. Average case time from start to finish to get a claim through the VA is about 6 months, right? Somewhere between 145 and 180 days to get the claim from start to finish. We don't need them distracted with this, right? We need to let the other professionals that work in case management, that work in social work, that work in healthcare, mental health care. We need to be able to grab those veterans when they come in and present for a claim, identify a potential co-occurring morbidity or a co-occurring need, and refer them off. We don't need our veteran service officers kind of working both of those pieces. So that's kind of the basis and kind of the rationale by which we're trying to make this repeal these 2 parts of the statute. Just not needed. And if we implemented as they're written, the state would incur a cost. There would be a cost associated with that. So that's kind of that's our position. And I'll use this analogy, right? So it's kind of healthcare navigators are a solution looking for a problem to solve, right? And we don't, that's kind of where we're at. So with that, I'll end my statements and I'll allow Ms. Altman to make any comments that she wants to make, and then we're happy to answer any questions you might have.
Again, good afternoon. I also extend my appreciation to the primary sponsor, Senator Carson, as well as Senator D'Alessandro, and as well as other sponsors. DHHS and the Department of Military Affairs and Veteran Services, as Warren has described, work in tandem to address the needs of individuals who serve or are currently serving in the military and their families. And they fulfill a number of those requirements of the proposed legislation already. As expressed in previous testimony, the close collaboration between the department and the Department of Military Affairs and Veteran Services, along with the support of the U.S. Department of Veteran Affairs, as well as hospitals and community mental health centers, worked to solve the intended goals of the statute already. Currently, we have established programs. I want to provide some examples of the way in which we work very closely with the Department of Military Affairs and Veteran Services. They devote a full-time employee to work with the department and collaborate to meet the needs of veterans experiencing homelessness and coordinate the efforts of our local, state, federal, and nonprofit organizations. They provide community-based programs and services for veterans also who are at risk for suicide. Additionally, our system of access for long-term services and supports also in New Hampshire, known as New Hampshire Care Path, and the Department of Military, Veteran Affairs and Services, the veteran service officers provide a more coordinated system. They do a lot of warm handoffs between each other. For example, when his staff find that they've been able to connect with benefits, but they also have questions about Medicare or caregiver supports, they're doing a warm handoff to our Service Link Aging and Disability Resource Centers, and sometimes doing joint appointments with the staff and working with the veteran and their families. Community mental health centers statewide have identified military liaisons to work and assist and support service members, veterans, and their families. And we also incorporate many of the military culture and ask the question components to ensure that the staff at the department have the competencies and the skills and the abilities to assist those who have served in the military and their families in many different ways. In addition to that, our Service Link Aging and Disability Resource Centers have agreements with both the White River Junction VA and the Manchester VA to assist individuals who want to direct their own care in the community and are eligible for long-term care through their VA. And they help support and provide options counseling for those veterans statewide. The department agrees that the funding these provisions to force implementation would provide to be redundant and wasteful, and that the funding these requirements would be throwing funds at a problem that was solved by the creation of the Department of Military Affairs and Veteran Services and the long partnership and collaboration we have with them. Thank you.
Any questions from the committee? Seeing none, thank you.
Thank you very much.
Thank you.
That is all we have for speakers. Is there anyone here that would like to speak, not given the opportunity? All right, I will close the hearing on Senate Bill 174.
Want to executive real quick?
No, we got a bunch of them. I'm going to open the hearing on Senate Bill 91, an act relative to the qualifications of dentists to administer general anesthesia or deep sedation. And I see we have Grant here to introduce.
Thank you, Madam Chair, members of the committee. My name is Grant Bossy. I am the Deputy Chief of Staff for the New Hampshire Senate, here on behalf of Senator Innes, the prime sponsor of Senate Bill 71, and he thanks you for your indulgence in allowing a pinch hitter today. Under current law, anyone undergoing a procedure, a dentistry procedure, who goes under anesthesia, there must be a qualified, dedicated anesthesia provider there in addition to the dentist. However, there is an exemption for dentists who are board eligible and board certified in the proper techniques. Senate Bill 91 would remove that exemption. You will not be surprised to learn that some dentists and some anesthesiologists have differing perspectives on whether that's a good idea. Senator Innes is trying to calm the waters and reach a consensus. He has not succeeded. He does not think he will get that done by crossover. He does, however, remain ever hopeful that he will be able to come to a compromise that makes everybody equally upset. We call that a Bradley special. He is asking your indulgence and suggests a motion to re-refer the bill that he may come back to you in the fall with a solution to the problem for your consideration. If you have any questions, I am not remotely qualified to answer them. But I can get them to Senator Innes, who can find somebody to get you an answer.
Thank you, Grant.
Thank you.
Next speaker is Michael Auerbach. Michael, did you want to get up and speak?
Sure. I don't know how I can follow up on that.
Grant is difficult to follow up.
Thank you again, Madam Speaker, and through you to the members of this committee, and deja vu all over again. One of the things, for the record, my name is Michael Auerbach. I am the Executive Director of the New Hampshire Dental Society. I am testifying today against SB 91. Every licensed dentist in New Hampshire must agree to a strict code of professional conduct that addresses a dentist's commitment to patient safety. This code is born of the American Dental Association's Code of Professional Ethics and Conduct, and is a set of principles every NHDS member in particular takes with utmost sincerity. In 2018, just for your edification, a bill was filed in New Hampshire that would impose new rules for dentists who perform deep sedation on children. This bill was born in large part of a tragic incident in California. The bill's sponsor, however, was unaware that the State Board of Dental Examiners was already writing new rules on this issue. The rules were to be built on scientific data and reliable input from such entities as the American Dental Association, the American Academy of Oral and Maxillofacial Surgeons, the New Hampshire Board of Dental Examiners, and others. After engagement by the NHDS, the bill's sponsors agreed to amend the legislation to let the Board of Dental Examiners continue its work on this important issue. Over the last year, the Board of Dental Examiners has returned to its work on this subject, examining whether it would be prudent for patient safety if a third professional was to be in the room during deep sedation of a small child under 13 years of age. The board is continuing to compile data and receive input. However, the proposal under consideration, lifting a blanket exemption for oral surgeons and dental anesthesiologists from rules that require a dedicated anesthesia provider to monitor the anesthesia process, has raised a great deal of concerns about the current rules, access to care, and the actual need for additional rules. The board is in fact scheduled to continue its discussions and collection of data next week. However, this bill seeks to circumvent the board's process by instead simply lifting the blanket exemption without careful examination of the impacts such a change would impose on dental professionals and their patients, particularly oral surgeons and their teams, as well as the patients. One must take into consideration the fact that in the event that a sedation-related incident occurs, there are already safeguards in place, both in the state's Dental Practice Act and in the rules of the Board of Dental Examiners, that hold accountable dentists who fail to adhere to the existing rules on sedation and patient safety. The NHDS understands and even shares the emotional response some of this bill's proponents have when we hear of an incident in other states in which a patient is injured or dies due to the negligence of a healthcare professional, whether that person is a dentist, physician, CRNA, or anesthesiologist, to whom they entrust their care. However, this bill would impose a new systemic response to a non-systemic issue. It will also impose new restrictions on much needed oral surgeons who move to New Hampshire while not necessarily affecting those who already work here, creating inequalities among new oral surgeons. It may also impose additional costs on patients' families, making sedation and the care they need cost prohibitive. Finally, it undoes the years of legislatively mandated work the Board of Dental Examiners has done and continues to do on this topic. It is for these reasons that I ask that this committee vote inexpedient to legislate on SB 91, and I'm happy to take any questions you may have.
Thank you. Any questions from the committee? Seeing none.
Let me off the hook. Thanks.
That is the last of the speakers on Senate Bill 91. If there's anyone here that would like to speak, if not, I will close the hearing on Senate Bill 91. And I open the hearing on Senate Bill 171 and invite the prime sponsor, Senator Ricciardi. Welcome.
Good afternoon, Madam Chair and members of the committee. For the record, I'm Denise Ricciardi, the state senator for District 9, representing Bedford and 13 other wonderful small towns south and west. I'm here today to introduce Senate Bill 171, relative to the definition of youth recreational programs, of which I am the prime sponsor. SB 171 makes a very small change that will have a significant impact on childcare in the state of New Hampshire. The legislation in front of you allows recreational programs such as those chartered by the Boys and Girls Clubs of America, incorporated YMCAs, YWCAs, who offer before and after school care to be able to serve school-age children. In the early 1990s, the legislature adopted a child care licensing exemption for recreational programs who served children 6 years of age or older, uniquely designed to accommodate the child care needs of working parents while recognizing the enhanced safety protocol and staff training requirements of these national organizations. At its enactment, the threshold age of 6 years was considered appropriate in light of the expected age of children who needed supervision before and after school. However, since that time, the state has allowed communities to enact full-day kindergarten programs that enroll school-age children who may be younger than 6 years. As a result of the inconsistency in these two age limits, the Boys and Girls Clubs and their fellow recreational programs are not able to accept some of the children of families that the recreational program exemption was designed to benefit, even though the characteristics of the need, the programs offered, and the qualifications of the provider are essentially identical. As you have all heard and seen anecdotally, the need for additional capacity in our child care and before and after school space is at an all-time high. We believe that this meaningful change will give parents and caregivers another source of quality programming that will allow them to maintain employment and stay in the workforce. Today, you will hear testimony from providers who think that this is a common sense enhancement to our statute and from families who would benefit from this change. I hope that all 5 members of this committee who have graciously agreed to co-sponsor this bill will continue to look favorably on the proposal and recommend that it ought to pass. I also have provided an amendment We are asking in the hopes that you approve this, that we could change the date so that it could be upon approval of this committee's acceptance, that it would take effect upon passage. And if you have any questions, I think I could possibly answer them, but we do have people who can speak to this a little further.
Any questions from the?
Just one, could you, it looks like you really need some more co-sponsors on this bill.
Oh, I'm so sorry.
Holy cow.
Yeah. Well, you know, we do have a problem, and this will solve a problem. Okay.
Seeing none. Thank you,
Thank
Senator
you.
Rishardi. Diane Fitzpatrick. Welcome.
Good afternoon, Madam Chair and members of the committee. For the record, I am Diane Fitzpatrick, the CEO of the Boys and Girls Club of Manchester, and here to provide testimony to support SB 171 legislation. Our club approached the senator to sponsor this bill. We want to thank her for doing so, and with me, Harry Malone, a board member of the Boys and Girls Club of Manchester, is here to show support. We strive daily to create a culture that welcomes all and provides kids from every background a sense of belonging in a safe environment. There are no barriers to our membership, no limits to what kids can achieve. The senator has stated that the youth recreational statute was established in 1990 as the legislatures recognized the autonomy of these programs offered by the Boys and Girls Club, YMCA, and Girls Inc. Incorporated, as well as robust safety standards that are required from our national parent organizations. When the law was discussed, most of the children were entering school at the age of 6 in first grade. Since then, communities and families have embracing the full-day kindergarten with increasing need for before and after school firsthand. I think I skipped a page here. Okay, sorry. We believe that SB 171 makes a critical change to the statute that will allow us to serve families much better. Not only does this current statute make children feel excluded from their siblings that are currently in our program, it prohibits them from attending, and also requires families to scramble to find alternative childcare. Recreational programs are a crucial component to allowing parents to continue to work while providing high quality, enriching curriculum that teaches important life skills, encourages physical activities, and offers abilities to establish lifelong relationships both with staff and friends. New Hampshire residents need to find essential high-caliber childcare across the state. As we move further away from the COVID-19 pandemic and return to some normalcy for our parents and their careers and children to be with their peers is critical. According to the most recent data provided by the After School Alliance, for every child in after-school care in the state, there are 2 children on a waiting list for available programming. This is not a silver bullet, but we believe adopting this SB 171 will be another tool of helping New Hampshire effectively chip away to the state child care accessibility issue. I want to thank you for your consideration and respectfully ask your recommendation that this bill ought to be passed. I'm happy to answer any questions that you might have. In addition, I have letters of support from 6 other Boys and Girls Clubs in New Hampshire, as well as Girls Inc., and as well as from our working families that could not be here to testify. Any questions?
Thank you, Diane. Any questions from the committee? Seeing none. Thank you.
Thank you so much.
Melissa, are you just here for information if we need it? Okay. If anyone is here that would like to speak and hasn't been given the opportunity, you're more than welcome. Seeing not, I will close the hearing on Senate Bill 171. Well, Cam.
3 minutes to get Senator Whitley here.
Absolutely. We will be in recess till 2:30.
So moved.
Second.
Okay. All in favor, say aye.
Aye.
I move, ought to pass on, Senator Rishardi's bill, whichever one it is.
171.
171.
All right.
Does it need an amendment?
No.
We have it, don't
Well,
we?
we
Well,
have,
it needs, ought to pass and a committee amendment to make it effective on passage.
Yep.
so, do we take a vote? Oh, okay. Yep.
So
I'll
moved.
offer that.
All right.
Seconded.
Any questions, any discussion on the amendment? Just changes the effective date.
Yeah.
All right. All those in favor of amendment 0256S, say aye.
Aye.
Opposed? All those in favor of,
Move ought to pass as amended.
Second.
all those in favor of 171 as amended, say aye.
Aye.
Opposed?
Consent?
Second.
All those in favor of consent, say aye.
Aye.
Opposed? And who would like to take this
Yeah.
out? Kevin Avard will be, Senator Avard will be taking it out.
Thank you.
Good work.
Take me one.
Read the bill?
Oh,
It's great. We were all sponsored.
50.
Which
Can
one?
I get
50.
I'm
50.
sorry. 65,
50.
65 screening panels.
Oh,
Where are we going next?
screening panels.
Oh, just jumping right in there.
Yeah.
Might as well get it over with.
Is there an amendment to that?
Well, I'll move ought to pass, and there is an amendment.
Second.
I'll move ought to pass on the Birdsall amendment.
Second?
All right.
So the Birdsall amendment would repeal screening panels. Thank you very much. So the quote-unquote compromise that was brought to us was a legislative study. I think we've actually already done that in terms of what was in the testimony that we got from the court system, and everybody should have gotten a memo from Commissioner Betancourt last night or the night before from the insurance department. I always want to try to bless a compromise, but I had long conversations with Superior Court Chief Justice Nedow after the fact about the burden that this is placing on the court system. It was even worse than what Mr. Head testified to. The fact that so few panels have happened in the last several years gives me pause. The fact that you can't get professionals on either side, either medical or attorneys, to serve on these easily. The fact that other states have moved to end medical screening panels, and the fact that the memo that we got from the insurance department saying that it really has negligible overall beneficial impact. I know how much of a struggle it was to create them. I served on the committee that oversaw them back, I don't know, 10 years ago when I first became a member of the Senate. So I offer this motion with some trepidation, and if something goes south and we now have just a flurry of situations, I will have egg on my face. So I just plead with the people that would be bringing these kind of situations to continue with the judicious way that they're brought.
Yep. And
Senator Whitley?
Thank you, Madam Chair. So, what I am sensitive to is the fact that, these cases are really hard, right? Where it's involving patients, it's involving,
really tough issues, and I'm very sensitive to that. And I think, while the intention of the panels were to address a lot of the problems here, things get settled faster, look at reducing premiums, it just doesn't feel like it happened. And I was particularly persuaded by the testimony from Attorney Kirkland, who had done a lot of that research, and she was pretty clear that, when the panels are used, it did not increase in cases getting settled before trial. It didn't speed up resolution of cases, and in fact, it increased defense costs. Right, so that's defense costs for doctors, right? So the other thing that was really compelling is that, this issue about premiums, that, a big driver, I think, for these panels was, we have to get these premiums under control. And what it sounds like that it's really, the issue is really the competitive of the marketplace. It's really, so I think that the issue of, these premiums are a problem. I know these are tough cases. It just doesn't feel like panels are the right answer to that.
Senator April.
In agreement with my two colleagues, also, there was one testimony from an attorney. It's almost as though it's already built into the system because it's a lot of these things are it's a contingency basis for some of these lawyers to take up the cases. There's statutory required independent physicians experts to support. Reputation is at risk, and on and on and on. So it seems as though it's already built into the system, certain protections, and nobody's going to take up a frivolous case without injury to themselves in cost. So I agree with your amendment, and I support it 1,000%. In one.
Do you want to say?
Thank you, Madam Chair. I do. So I actually feel that the underlying bill was really the compromise, in terms of suspending these panels and studying them. And it's not lost upon me that a majority of the testimony that we heard were about how this hasn't worked, but not, so how it hasn't worked. And what Senator Whitley just cited, that testimony in particular was very compelling. But, my struggle with the amendment is that we still don't have a way to solve the problem. And although I do feel like, but I think premiums were a major piece of it. I know that others have studied this. We haven't, and as a legislative body, and so I'm not going to support the amendment. That's all.
Fair enough.
Oh, and I just want to say that I have heard from, I have now 4 hospitals in my district, and 3 are in the same health system. But I have heard from the healthcare community that they would like to just go with the underlying bill. That's all. Thank you.
Okay, where are we?
So we have the amendment's been moved and seconded.
Okay. So all those in favor of the amendment say aye.
Aye.
Aye. Opposed?
I'll move on to pass as amended.
Second.
All those in favor of ought to pass as amended say aye.
Aye.
Opposed? And who would like to take this out? I can take it out.
Anyone, just to re-refer?
Sure.
Quickly.
91. And that is the dentist.
Yep.
And the sponsor, where's that? The sponsor wants to re-refer.
I move to re-refer.
I'll second that.
All right. All those in favor of re-refer say aye.
Aye.
Opposed?
Consent.
Second. I'll second that. All those in favor of consent say aye.
Aye.
Opposed? All right. Senator Avar will take it. I can't even find it.
It's easy. It's easy.
Oh, good point. 174 relative to veterans' access to health care.
Move pass. Second.
All right. Any discussion?
Can we hold on this one because I didn't hear this hearing? And I have heard from some folks that shouldn't we just at this point suspend rather than repeal? So I would like to hold this one. And I didn't get to hear the testimony.
We can hold it till next week.
Appreciate it.
Withdraw my second.
Right. About 32, the opioid abatement trust. There is a Bradley amendment. 0082S. Do you all have it? Basically, it puts back in the state's political subdivisions, community health centers, and, oh wait, that's not the right one, is it? And not,
32?
82.
Oh, 82.
82 is the amendment,
Bill is 32,
Okay.
amendment is 82.
right? But wasn't there,
I thought you were coming in with another amendment.
I thought there was another,
82S, right.
that may be my fault, because I thought that, wasn't I talking to you yet last week to add language?
Yes, for the help, the hospitals.
Yeah.
To be put back in.
Well, yeah, but then I also wanted language put in there that, Paula, we talked about language for third parties. So basically, what I'm looking to do, put it back in, and then just for clarification, in the not-for-profit providers, put in a clarification that if they're otherwise reimbursed by a third party, like if a hospital's been reimbursed from an insurance agent, they're not eligible.
Could we do a committee amendment?
Yeah, I mean,
Can I speak? Paula Minahan, Hospital Association. Sorry, I don't think we did have a chat. I didn't come up with any language. Is this the language? Oh, John, he's magic.
You could have done that a little faster.
Nice job, John.
He's helped me more than once. Okay, well, here's the amendment, so we're adding back the community health centers and non-for-profit providers.
with a caveat for the not-for-profit providers.
Right, and what we had talked about, Senator, was notwithstanding, what was it? Notwithstanding no other reimbursement has been received or something to that effect. We don't want double dipping. I don't like that term, but that's really what we're trying to avoid. So notwithstanding no other reimbursement would have otherwise been received by such
Does that
non.
go at the beginning of the sentence?
Yeah,
or at the
that
end?
probably belong. Yes, reimburses too.
So it's line,
It would be line 20,
not 28, right?
Reimburses state within.
oh,
the
I'm
state,
sorry, I'm looking at the.
but not limited to services provided to.
People currently previously involved in criminal justice. Is that like line 28? On page, on the first.
Maybe we should hold this and work on an amendment so we can think it through a little more. Do you want to, I have another question.
Sure.
You could do it at the very end on line 23 and just say after the word providers, as long as no other reimbursement has been received.
That works.
For such, for
For such services.
something like that, for relevant service or such services. I think that could work. But
So my other question, if I may, Madam Chair, Senator Rosenwald just wants to make sure that this would still allow for reimbursements for treatment while someone is incarcerated.
That's no one on
I don't think, go ahead.
So lines 19 and 20 and 21 still contain the initial references to people currently or previously involved with the criminal justice system. So I don't think that language was touched.
So I just want to make sure that includes incarcerated individuals.
I'm not an attorney, but currently or previously involved with the criminal justice system.
John
think
is
it's even
John
broader
is shaking his head yes.
I mean, it's a little loose, right? Involved in, what does that mean?
John? Yeah. Is John Williams here?
As long as no other reimbursement is
Senator Whitley, thank you very much. I just have to be very clear. I work for the Department of Health and Services, and our issues have been addressed on these previous sections in lines 8 through 12. So thank you very much for the committee. The remainder actually was made at the request of the actual commission, working along with Attorney James Buffetti, and also with Senator Rosenwald on the bill. So I would have to defer exactly just from common place language that the word currently being involved in the criminal justice system. I would represent, that's the original language that the commission had requested. I believe that there possibly was also testimony on that point that it would include both those currently or previously as part of the criminal justice system. Very, very broad definition, so it made sure that it would have some flexibility for the use of those funds, was my understanding. Again, I represent the department. This provision of the bill came from the commission. Thank you.
So can you repeat that language back?
Well, that goes back to the other thing, but talking about the incarceration, I think, Senator Rosenwald, people currently involved with the criminal justice system is broader than people just
Right.
incarcerated. So you could be on parole and get Medicaid, medication-assisted treatment under this language. Previously, it would just be incarcerated people, the way I read it.
So maybe a question should just be asked on the, I don't know, I know we would probably want to put it on consent, but we maybe wanted to ask a question on the floor just to make sure that's in the record, that it does include current and
We
formerly
can pull it off.
incarcerated.
I mean, we don't have to put
Well,
it.
we don't have to put it on consent.
Yeah, let's do
Right.
that, and then we can, and then, maybe whoever brings it out, Senator Rosenwald, can ask that question just to confirm and put it in the record.
Maybe you can bring it out and ask that question.
Here we go.
That's why he's chair.
Vice chair. It's vice chair.
Yeah, let's do that. I can bring it, we'll keep going.
Well, we got
Getting a little ahead of ourselves.
All right, so
Can we get the language
All right,
again?
so what, because this phrase ends with not-for-profit providers, normally you would say providing no other reimbursement, but providers providing. So I said providers, as long as no other reimbursement has been received for said services.
second.
You got that? Cam?
So the language that Paula said include the word otherwise. Is the word otherwise important? Otherwise reimbursed? Or what I had down from Paula was as long as no other reimbursement would otherwise have been received for such services.
All right. All right.
And it's been seconded.
Who motioned?
Deb motion?
Oh, okay. Second. All those in favor of the committee amendment 0082S, say aye.
Aye.
Opposed? And Senator Whitley will be taking it out.
I second. Well,
There you have it.
I
It's
second.
got a ought to pass as.
Oh,
Amended.
sorry.
Did we get Jeb's?
I'm getting ahead of myself.
Did we vote on Jeb's amendment?
Yes.
That was included in the
Okay, yes.
Amendment
Okay,
82.
Other amendment, gotcha.
So now someone needs to move ought to pass with
I
amendment.
move
So
ought
moved.
to pass as
Seconded.
All those in favor of ought to pass as amended on Senate Bill 32, say aye.
Aye.
Opposed? Senator Whitley will be taking it out.
And asking that question.
Thank you.
Lines Bill 50.
Yeah, that's what I got
I
here.
move ought to pass on Senate Bill 50
My folder.
That is Senator Lang's bill on the pharmaceutical. There is an amendment. He got the,
I'll second it for discussion.
I told you HHS is gonna be interesting with the two of us here.
I'm here to help you.
So you second the bill, but no one's moved the motion,
The amendment.
the amendment, excuse me.
I'll move amendment 024S.
I'll second. Third it.
And Senator Lang got the two individuals together. They agreed on the language of the drug take back. So has everyone had a chance to look at it, review it, and are they okay with it? Okay. All those in favor of amendment 024S, say aye.
Aye.
Opposed? All
Move ought to pass as amended.
Second.
Senator Whitley seconds. All those in favor of Senate Bill 50 as amended, say aye.
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 I move
Opposed?
consent.
That was too quick. Yeah.
All those in favor of consent, say aye.
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 Opposed?
I'll take out a consent. I'm kidding. She can do that.
Senator Prentice, would you like to?
Love how we're starting out so agreeable.
Fighting over the consents.
It's early. Um, 172.
Yep. that's all it
Allowing
is.
court-appointed guardians to.
I move out to pass.
A second.
Okay. Do we have any amendments on this one? No. Good. Okay. Any discussion? All right. All those in favor of ought to pass on 172, say aye.
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 Opposed? Consent?
Consent.
Second.
All right. All those in favor of consent, say aye.
Aye.
Opposed? All right. Kevin Abard, Senator Abard will take it out. '83. That is relative to the signature authority of an advanced practice registered nurse or certified midwife.
I move out to pass.
Okay. Any discussion? All those in favor of ought to pass, say aye.
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 Opposed? Consent?
I move consent.
Senator Whitley moves consent.
Second. Second.
Senator Prentice, take it out. All those in favor of consent, say aye.
Yes.
Aye.
Opposed? Senator Prentice will be taking it out. All right, last one. Do we have an amendment on 85?
No.
Oh, so we can't really do it. Do we need? Well, we're waiting for one.
We're waiting.
Okay. All right,
Good job.
we're gonna hold on.
We talk about a couple of others.
Sure.
So 173. This was my bill last year. This was the one the insurance department testified to. The issue is the sole authority. I would hope that Henry, Paula, anybody interested would reach out to the
insurance.
commissioner and try to come back with a compromise. Last year, we stripped that out. You heard, what they said in terms of whether you want to have a broken system from Washington that's not up and running, working, or maybe diffuse the commissioner's authority in some way vis-a-vis an amendment. But I think that would be my recommendation on that one.
The ground ambulance as well was an issue if we're gonna.
And I did talk to Chris Staywas, and I asked him to come in with an amendment with language that exempts them, and I think Sue would probably take care of that.
I'd be happy to. And then,
Page 2, line 37, right?
I think, yeah, here. Okay. I have one, yeah, on 173. So there's a difference of opinion between the commissioner and I on air ambulances. And I've Googled it to, I've Googled it to the end, and I stand behind that we don't have the authority to regulate air ambulances. And there are other, jurisdictions that have supported this. So what would suffice to get good clarity? It's a difference of opinion between the commissioner and I on this. So where do I lean into to get the clarity that we need to then discuss this with the commissioner again and see if he wants to continue to keep this language in here?
I missed this here.
Well, you're the senator.
Do we need a legal opinion from the?
Yeah, I know. I agree with you too. So it's like, but I'm not a. It seems like I agree with you.
I think it's very well documented, and I appreciate his passion, but I don't want to see anything move forward that ends up, before. We have 2 circuit courts in the country that have said that this is a no-go. And not on this side. And he made it clear respectfully that he disagreed, and we disagreed last year. So I think I owe them both a soda, but what do we want to?
Do you want to include that in your amendment?
Striking it?
I mean, it sounds like you have support from the committee on your position.
Okay.
If we decide to pass it, yeah, the whole bill.
Yeah, I will share with you all. I can share by email just the different citations that will maybe help give a little, a little more context to my concern about this.
So let me see if I've got this right. They said that they have they're not in charge of the air ambulance when it comes to the flight patterns and such, but the billing aspect, they're saying they do, and you don't think that they do.
Under the Airline Deregulation Act and 2 previous court cases, it says it includes not only all of the flying, but it includes the billing. So that, and the commissioner respectfully said that's, his or their opinion or their position on this.
Page 6.
No,
Yep, so
okay.
that's where
Contrary to
that's where
federal
the
law.
disagreement is.
And their court can
I will get the 2 different citations. They're from other circuits, but yes.
Did they have a legal basis for their position?
I didn't push that. I
Okay.
didn't. I mean, he obviously he knew that I was going to disagree with it again,
Sure,
which is fine.
sure.
So I would be, yes.
All right. 178, certain specialty formulas. I mean, Senator Bradley wasn't here for the hearing.
I wasn't either. Yeah.
Okay, so why don't we wait?
It also sounds from we're waiting to hear back from CMS whether it's permissible under in and out.
Oh, that's right, okay. All right. Any other discussion on any other, that's all I want to exec today.
Cam, can you list the bills that have been heard that we need to still exec, just so we have it?
Heard but not exact. Senate Bill 36.
Okay.
85,
Senate Bill 85.
86,
Senate Bill 86.
173,
Senate Bill 170.
170.
Senate Bill 173.
Yep.
Senate Bill 174.
Mhm.
Senate Bill 176.
Mhm.
Senate Bill 178.
Mhm.
That should be it.
Yep. Can you do that again, just so?
Yep. So, 36, 85, 86, 170, 173, 174, 176, 178.
Good job.
Any other topics, discussions?
Motion to adjourn.
I'll second that one. All those in favor say aye.
Aye.
Opposed?
You did an amazing job.
All right. Thank you guys for holding that for me.